So, sir, the order will be, we'll start with Akshay and then sir will have some opening remarks. Then Akshay, first talk Akshay, then Rohit you, then Soumya. We are going to go with nationality first, Indians first, then US, and then somewhere in between Singapore and UK.
Yeah, that's good. We have an Aios session next. I have a community ophthalmology session also. So
okay.
Good.
So we will let you
that's good. I'll drop out in the middle quietly without making any noise.
No problem. You can make noise and leave. No problem. So,
hi, everyone. You hear me okay?
Yes, Bharti.
Yes,
yeah, hi, everybody. Yeah.
I'll just share my screen so that we're all, if possible.
You all can maybe, yes, we can see. You want to run through your slides quickly?
Yeah, so it's okay?
Yeah, it's okay, I think.
Great, I'll stop here.
Okay. Anybody wants to check their screen sharing?
Yeah, I'll try sharing.
Yeah. Yeah, visible. We can hear you.
Let me just see this. It's advancing as well.
Yeah, advancing. Okay. Yeah.
Maybe here too. Just because I have a video in there, I want to make sure it's playing.
Yes. You can. You have some time to check. Sorry to drag you, all three of you, from very early in the morning. You, Ekta, and Preeti.
Yeah, no worries. Absolutely, it's a pleasure.
But I'm hoping it's Saturday, so you all can sleep in later.
The kids are going to wake up as soon as I decide I want to sleep.
Yeah. That's what husbands are for. They can take care of it. Yeah, we can see your screen, Bharti.
Okay.
Go through it directly, we'll see if it's playing.
Yeah. Okay, perfect. Okay.
Yeah. Ekta, you want to check your screen? You want to? Yeah, that looks okay.
Thanks.
I think
I hope somebody from the tech will tell us.
yes. Oh.
We are connected to Hall C, no?
Yeah, sir. We are in Hall C. That link directly takes you to Hall C.
Dr. Frank is back.
Yeah, I think we will just ask him to give a brief intro.
Hello.
I know, Professor Frank, I think it's too late in the night. I think you just give an opening remarks and then you can take it easy. Just opening remarks.
So you're mute.
Yours is mute.
Tech team.
We can't hear you.
Dr. Frank. Dr. Frank,
It's mute.
you can hear us.
I'll send him a message maybe.
Yeah, I think so.
Can the tech team unmute him? Probably they should be able to.
Is the tech team on? It's time, I think.
Tech team is off camera and off this also.
Hello, ma'am.
Yeah.
Sir, I'm from backend team.
ये पूछ रहे थे टीम से स्टार्ट कर दे.
So you will give us a cue when to start. Tech first. Lot of background noise and lot of background noise from tech.
Good evening, everybody.
Now we can hear you, Professor.
Can you hear me now?
Yes,
Yes,
yes.
sir.
We can hear you. Thank you. Please,
Good.
please.
Good. Thank you very much. Well, this looks like to be a wonderful symposium. Strabismus is a fascinating science. Every patient is different. And this evening, we've got outstanding speakers who are going to share their experience with the audience. I'm sorry I can't be with you, but I look forward to my next visit to India. Thank you.
We also look forward to it, Dr.
Thank
Frank.
you and look forward, sir. Thank you, sir. Thank you for your blessings. Well, on behalf of Professor Frank Martin and Asia Pacific Pediatric Ophthalmology Society, I welcome all of you for this wonderful evening program in India and a couple of speakers from abroad. I have great listing for Dr. Sumita Agarkar being the Deputy Director in our department, and also thank Professor Namrata for giving this opportunity to address this conclave. I also have with me my latest colleague, Dr. Akshay Badarke. And of course, I think all of us know about the rest of the speakers. Let me not take much of your time. We thought we will make it different, that what you have made something different in 2022. So in pediatric ophthalmology, let us start. Thank you.
May I request the first speaker, Dr. Akshay Bhatkare, to get ready with his screen. And Dr. Akshay is a pediatric ophthalmologist from Shankar Nethralaya, Chennai. He did his fellowship from LV Prasad and was a consultant there for some time. And we are happy to have him talk on what did I do differently about strabismus in this ASPOS session. Welcome to all the audience. Thank you.
Good evening, and thank you, Sumita ma'am, and thanks everyone for the opportunity. It's great to see everyone online, and especially to meet my close friend, mentor, guide, Dr. Preeti, whom I'm seeing after so long. Really nice to see you, ma'am. So it's a very nicely titled session, What did I do differently in 2022? And I've titled my talk as Not Always Surgery. So through that, I have no financial disclosures. We have obtained consent for clinical photos and videos as well. And we'll go through an illustrative case. We'll look at how screen time can affect the eye and systemically as well. We'll go through what acquired esotropia is, the workup for acquired esotropia, why we choose Botox, and I'll conclude after that. So the story begins with a 7-year-old girl. She was brought in by her parents mainly with double vision and inward deviation since 8 months. On probing a little in detail, it was revealed that she was having exposure to to handheld gadgets for almost 7 hours a day, 4 to 5 hours of coaching sessions every day, and music lessons via smartphone. And apart from that, also some recreational activities for an additional 30 minutes. On examination, she's best corrected visual acuity is 6/6. She's N6 with and without glasses. Cycloplegic refraction was +1. Her stereopsis was 40 seconds of arc. Extraocular motility was full and free. Her strabismus evaluation revealed a 35 prism diopters of intermittent esotropia. This was a comitant esotropia, and she had uncrossed diplopia on the red filter test. We looked for cerebellar signs. There were none. Her cranial examination was normal. Anterior and posterior segment were within normal limits. So we came up with a working diagnosis of acute acquired comitant esotropia. Now, this is not something new that we have seen in the post-COVID era. This is a paper by Dr. Nina, which has shown that almost in her paper, almost 11 subjects were children, and almost all of them had nearly 8 hours of near activity on smartphones and other devices. And she also concluded that exposure to smartphones for so long is a risk for acute acquired esotropia. Apart from this, it can also lead to stress and anxiety, sleep disorders, metabolic issues like obesity, insulin resistance, increased levels of stress hormones, and it can mess up the circadian rhythm. So not just the eye, but the systemic factors is something that we need to keep in mind. Our experience, this is some unpublished data that we have gone through. From March 2018 to Feb 2021, we have had 59 patients of AAC. And what is interesting is the screen time. You can see that pre-COVID, the screen time maximum was 2 hours in the 2 to 3 hours range. And this has almost tripled in the COVID era, in the post-COVID era. This has led to an epidemic of esotropia. Now, if you look at a simple PubMed search, will show you a lot of articles on the effect of digital eye strain on the eyes of children. Now, what is acquired esotropia? It's a relatively rare and distinct subtype of esotropia. It's a non-accommodative deviation. It can result in 2 ways. One, it can result from a deterioration of a pre-existing well-controlled esophoria, or it can present acutely as an esotropia with diplopia, which we call as AAC, and it contributes to about 0.3% of childhood strabismus. There are 5 subtypes. Type 1 occurs after a period of interrupted binocularity, typically seen in children after a period of patching. Type 2 is known as the Burian-Franceschetti type, which has very minimal hypermetropia, but normally some physical or psychological stress leads to esotropia. Type 3 is the Bilchowski type, seen in myopes. Type 4 is the refractive accommodative type, and probably this is the easiest to correct. Good cycloplegic refraction and glasses take care of the squint. And type 5 is associated with posterior fossa lesions and intracranial pathologies. So coming back to our case, we asked for the old photos and it confirmed what the parents were saying. We got an MRI brain done, which was normal. We also did an orthoptics workup and atropine refraction. We tried a prism trial. The child was not comfortable with prisms. So the next option that we had was either surgery or Botox. Now, Botox is not something new in ophthalmology and in strabismus. It's been used for quite some time. And if we go through literature, the consensus among people using Botox is that, one, it is convenient. It needs very little time. It's a simple technique. Whether we do the transconjunctival technique or the open sky technique, it's very simple. Learning curve is not steep at all. Very minimally traumatic. It is cost effective, and the outcomes actually are quite similar to surgery. So in our case, we gave 3.5 international units Botox to medial rectus bilaterally. We also advised the parents about the importance of reducing the child's screen time. This child was using screens for almost 7 hours a day, and lifestyle changes also were advised. In a short surgical video of the procedure, a small fornix incision is made. Then we hook the muscle. Then with a small hook, we actually just tent up the conjunctiva to get to expose the muscle nicely. And using a 30 gauge needle, about 4 millimeters behind insertion into the muscle belly under visualization, the Botox injection is administered. We also must take care to ensure that there's no spillage of the injection after it is completed. So this is the result at 4 months. You can see well-aligned eyes. Child is actually, we have advised her not to use glasses because she is doing well without her glasses as well. And my personal experience is that I have administered now 12 cases of Botox in AAC. The median age is about 8.7 years. You can see the deviation ranges from 16 to 45 prism diopters. I use an open sky technique. One case had residual esotropia, but this patient is doing well with prisms. The follow-up period is short, mainly because these are outstation patients, and sometimes follow-up can get missed. But those who have come, they are doing well up to almost 4 months post follow-up. One child had ptosis. This is a known side effect in Botox, and typically it resolves within about maximum 3 months. In this child, it resolved in 2 weeks. So I think for AAC, what is important is a complete good history taking. We need to probe into what could have possibly led to the esotropia. Our ophthalmic examination should also be very thorough. Atropine refraction, orthoptics where needed. Neurologic exam in the OPD can be done in a very simple manner. Just the Romberg sign and looking for the finger to nose test are give us clues about any central nervous system involvement. Cranial nerve examination also helps. And I think AAC, we should look at it as a diagnosis of exclusion. So we should do an MRI brain, make sure that there is no CNS pathology, and then go ahead and do the give the treatment. So I would conclude by saying that AAC requires a complete ophthalmic basic neurologic workup. Do not hesitate to image. Lifestyle changes and education. Education not just of parents and the patient, but I think even in public forum, educating schools that while screen devices and these gadgets are fancy, they may not be the best option for our kids. And Botox is definitely a viable option. With that, I would like to conclude. Thank you for the opportunity and for the patient listening. Thanks a lot.
Thank you, Akshay. I think just the easiest calculation for Botox. I don't know how many of you remember I started Botox in 1989 itself, and also last used the Botox for. Nowadays, I don't use it for strabismus. The easiest calculation I had to do was, suppose it is 40 prisms, we give 4 units, 30 prisms, 3 units, like that. Very easily I could calculate, though the Alan Scott protocol was a bit different. But in my hands, I think this worked out better. It's an excellent paper, and the results are good. Hope, I think we will follow it up, and yes, the child doesn't develop again. And, probably you must have stressed the child not to use too many gadgets.
Yes, that is the important aspect.
Any other comments?
21, 22 were years of AAC. I don't know if other people also same experience, but we did see a fair number of children with this in last, not so much in 20, but 21 and 22, lots of cases. Anybody wants to add their points in this? All are welcome. All the entire speakers, everybody is a pediatric ophthalmologist.
Yeah, I think we did a lot of acute esotropias too, screen-induced when they were doing online schooling. So my technique differs a little bit. I do transconjunctival rather than opening up the conjunctiva. So I usually explain to the patient, it's like getting a vaccine injection. You get a vaccine and you're done. It takes a minute to do it. So what we basically do is hold the muscle with the hook. So we know we have the muscle, and then just go ahead, bevel up and go and inject in the muscle. That's what we have been doing.
Yes, I am also given transconjunctival, but I think your position and accuracy is much better if you do open sky. But
absolutely,
yeah. But
the kids you're doing under GA.
Yes. Anyway, all the injection you are going to do a GA under GA only. Only thing is sometimes, yes, I think if you give transconjunctival, ptosis is a little bit more, is my personal experience.
Yeah.
I mean, to add on that, if you go transconjunctival, then I have had more ptosis. Invariably, there is some ptosis.
I think initially we were using the DMG machine. I think with the tungsten needle, you just pierce the muscle without opening the conjunctiva. But I think neither the tungsten needle is available nor the DMG machine. Both are obsolete now, unless you have a very big setup. What I had was a very portable, small DMG machine. Anyway,
Smita, if I may add, just to stretch the discussion a little bit, injection of Botox for strabismus and thyroid eye disease, your experience, because I give it transconjunctival in the clinic without a cut down, and that's been my standard practice. How about all of your experience?
Yes, that's what we were discussing just a minute before. And I said, most of us, children, I think we all give transconjunctival, but I think one or two of my colleagues do give open sky the way he showed in the video. But transconjunctival does well, but only my problem with transconjunctival has been a little bit more incidence of ptosis compared to if you give directly under direct visualization. Like sometimes if we have augmented in medial rectus recession surgery by giving Botox, I haven't seen that much ptosis as I see when I go transconjunctival.
I was asking for thyroid eye disease.
I know.
Restrictive strabismus, we don't give Gangadhar Sundar. And also, this is pediatric ophthalmology. So we confined to pediatric ophthalmology. Welcome, Gangadhar Sundar. Thanks for your last minute invitation. I think to join this.
Honored to be with you all.
I just wanted to make a quick comment. I do transconjunctival as well. And for the ptosis, what we've been doing is just asking the anesthesia team to raise the head end a little bit. So just to raise the head end and give the injection, and then even during recovery to keep the head end raised. So I've been doing it quite a lot here, especially for children with developmental delay. I've only had one with ptosis in over 30, 40. I don't know, maybe the head end raising might help a little bit.
That's a very helpful suggestion. Thanks, Preeti. May I now request Dr. Rohit, because he has to go and join another session, to give his talk on what he did differently for myopia in 2022. Dr. Rohit does not need introduction. He's a professor, a very young-looking professor in RP Center in All India Institute of Medical Sciences. Humongous amount of work in neuro-ophthalmology, pediatric ophthalmology, community ophthalmology, and in myopia. With that, I welcome Dr. Rohit to deliver his talk.
Thank you, Sumita. Thank you very much, Aios and Asia Pacific Strabismus and Pediatric Ophthalmology Society for giving me the opportunity. And it's great that we are discussing myopia immediately following acute comitant esotropia, both of which have had this issue of tackling the challenges post-COVID and the attitudinal change that has happened. So I'll talk about what I did differently, or what we've learned differently that's kind of changed our management in the past 1 year or so. Firstly, we all knew this 2016 paper by Brian Holden Group that they projected 50% of the world's population would become myopic by 2050. Somehow, even although this was a rather startling paper, I thought that there was not so much change, and we all thought that myopia is important in India. But I personally never thought that we're going to get so worried about it as fortunately or otherwise we have to become now, considering the data. So this was one of the reviews that we did. This was a systematic and review and meta-analysis of all data published in India, whether it's in PubMed or just Google. These were studies that were taken from 1980 to 2020. And the reason we did this was that we realized that Brian Holden in their review did not actually include Indian studies because they did not feel that there were enough robust studies. So while this does not include very robust studies, but we just thought at least we get an idea about the trend of myopia over the 4 decades. And we were startled, to say the least. Overall crude prevalence in the last 4 decades was 7.5%, and this was over 4 decades. Urban was high, 8.5, and rural was 6.1. Again, not that much different than what we were that we thought would be. And highest prevalence was coming close to 15% in the urban region, with 11 to 15 years age. So we're looking already at 15% in urban areas in parts of India. And the other thing was this significant increase in the last decade in the rural children, from 4.6% in the previous decade to 6.8% in the last decade. So it is a huge jump, and we know that something is happening. And this was the big attitudinal change for me. This pressed us all to evolve treatment strategies. And of course, a lot of pediatric ophthalmologists had got together to devise treatment strategies as a consensus statement that hopefully will get published shortly. But briefly summarizing it, these are the key steps and key things that we want to talk about. A lot of change has now happened because we are now remembering and understanding that it's axial length change that is important. And that is something that we need to measure when we're seeing. The identification of risk factors and acknowledgement of their major impact on development and progression of myopia. So we know younger the age of onset, greater the chance of developing vision-threatening complications. And a huge progression of myopia has been seen in the last decade in the 6 to 11 years age group. So younger children are now becoming increasingly prone. Remember, this data analysis was pre-COVID, so our previous discussion on increased screen time is probably worsened the situation. Females, for some reason, show faster progression. If both parents are myopes, then the risk is 3 times than in the general population. And Asian children, although it does not actually include Indians, is more risky. Our greater understanding has occurred in the environmental factors and the visual environment, not spending time outdoors, increased close distances and continuous periods of reading, and of course, minor effect of physical attributes. These are key understandings that have now become very, very important and something that we must take into consideration when we are managing a child of myopia. It's now considering the huge treatment options that we have, particularly in India. It's important to select a treatment based on and the aggression of your intervention based on the baseline refractive error and the age at which you are starting intervention, the binocular vision status. Again, a recent understanding that children with accommodative lag and near esophoria are more prone to develop progressive myopia. Understanding ocular surface, or at least evaluating it, because in treatment options require that, pupil size, drug allergies, ethnicity, and of course, overall safety, compliance, and cost considerations are a major say now for selecting the treatment. We all know that a cycloplegic refraction is very, very important, because lack of cycloplegia will increase the risk of miscalculation of the amount of refractive error and reduce the repeatability of your refractive error measurement, which can change your understanding of how fast or slow a child is progressing and the effect of the treatment you're giving. So your refraction method should be repeatable. Open field ARs have now become advisable in evaluation and follow-up, because it helps to reduce the variability of residual accommodation despite cycloplegia. And of course, you need to regular follow-up and make sure that your method of refraction is repeatable. As I mentioned, axial length measurement has now become a key investigation in evaluating a child with progressive myopia. Amplitude of accommodation, pupillometry, and measurement of other ocular parameters is also becoming important. Binocular vision assessment, including stereopsis, accommodational lag, and amplitude of accommodation, is now a relatively important measurement, because as I will mention, as I will talk about, it does affect our decision making in what we are going to test. Other exploratory tests which are still coming up would be peripheral refraction, and there is a lot of discussion on peripheral refraction everywhere. Again, because intervention methods are taking this into consideration. Pupillometry, because atropine makes a small but significant difference in the pupil size. Abrometry, and of course, macular OCT, which is believed that subfoveal choroidal thickness may also be something that is being impacted by our pharmacological interventions. We have huge number of options, and we are lucky in India that we have access to a lot of these. We have multiple forms of optical interventions of various kinds of spectacles, contact lenses, pharmacological interventions, which are approved by the regulatory authority. And of course, the key intervention, I think all of us must remember, are the environmental changes that we must advise our children to increase outdoor time and have high indoor ambient illumination whenever the child is doing any close related work. It's important to identify whether a child is a progressor or not. A younger child, a very small child coming with myopia, you may be identifying a child who's part of or in process of emetropization, so may not require any aggressive intervention at the moment. Maximum intervention is to identify a progressor in the 6 to 12 years of age and aggressively intervene if he is progressing. Rate of progression is going to decide how aggressively we are going to intervene. The ocular surface will tell us whether we can use contact lenses as an intervention method, binocular status, and of course, the environmental and genetic factors decide how and how strongly we are going to intervene. I'll talk about the lifestyle modifications, which are a must. We know that about 2 hours a day of outdoor activity is recommended and is considered to be protective. Reduced near work and near screen time, a challenge now in the current children, and environment modifications like frequent breaks, high ambient illumination indoors, good posture, good reading distances, and have multiple breaks after every period of time. Again, as I mentioned, low dose atropine has been available now for a very long time in India, and a lot of studies have provided good effect of this intervention in almost all races, particularly including India. We have also been using 0.05 in rapid progressors, and we hope that there is an ongoing clinical trial that is ongoing, and we hope that that concentration also will be available with in India shortly. And of course, it currently is the sheet anchor of treatment. Multiple spectacles, particularly peripheral AD lenses, are available now that act by causing a myopic defocus in the mid-periphery that reduces, or it is proven or shown to reduce progression in children who have hyperopic defocus in the periphery. In fact, it's supposed to show good effect in almost all children. Almost 70 to 80% of children have shown to respond very well to these kind of spectacles. Prismatic bifocals are available now for particularly those children who have accommodative lag or esophorias. Orthokeratology, unfortunately, we do not have too much experience in them, but we hope that a little older children may accept orthokeratology as an option. And again, that has also shown to be highly significant. So we are having huge options. And again, soft multifocal contact lenses, which incidentally were initially the presbyopic correction glasses that were used, but now we have myopia specific FDA approved lenses available that have shown good effect in reducing progression of myopia. So a lot of options are available, thankfully, now in 22 onwards, and you need to choose what you are going to do. You need to analyze treatment efficacy in terms of myopia progression, in terms of axial elongation, and change in other parameters, and assess how much it is effective. Treatment may be stopped or switched if it is not sufficiently effective, or there is poor tolerance or side effects. And of course, compliance is may be an issue. It is must, and thankfully a lot of us have got together to have public health approaches, talk to parents, talk to caregivers, talk to policymakers, and that is something that all of us must take out time to ensure that policy changes are made in the education system that will reduce the risk factors that increase risk of progression in these children. So to conclude, analyze the patient's risk profile, select patients who fit into the criteria for whatever intervention you are planning. Most important, to educate parents, children, perform baseline evaluation. Axial and parameter testing is important, and a must is environmental modifications for all children, and we must increase awareness. Thank you for the opportunity to talk on this so important topic.
Thank you, Rohit. Have you combined both TIMS and also weak atropine? Because I have tried a couple of cases. But important thing is that take away the smartphone, because they play cricket also with the smartphone nowadays, apart from WhatsApp messages. So the outdoor games becomes indoor games. So I think what I did for my children is to knock off the cable TV till they graduated. So there was no TV at home at all. Now we have 3 TVs. So like that, I think smartphone has to be cut off. The parents have to sacrifice. And then only they will go outside and play.
Yes. Phones are only for talking. In children, phones are only for talking.
What about your trial of clubbing both TIMS as well as weak atropine?
So, sir, we've tried them only in those who are showing progression even after 1 year on any one of the criteria. And the effect does appear to be additive, although we still don't have more than a year of follow-up of these children to see whether there is a substantial impact on the progression over and above what they were using previously. But at least internationally, a few studies that have come have shown that both optical and pharmacological interventions, if added together, possibly act through different mechanisms, and therefore may have an additive impact on reducing rapid progressors, which we will tend to define as increasing more than 0.75 diopters a year.
TIMS, actually, we have now 3 companies which have come forward.
Yes.
I'm sure I can.
Augurs well for the options that are now available, including the pharmacological, as there are so many companies manufacturing 0.01 at least for the moment.
Just had a question to ask. In terms of 0.01% atropine, when we're using it more than once in a day, say twice in a day, have you seen any pupillary changes with those? I've had a few kids who've had, though there is no complaints with the near vision or anything from the children, but using it twice a day has altered the pupillary size a little. I'm not sure if it's just an observation.
I haven't tried 0.01 twice a day. Actually, whoever we feel that is not responding adequately 0.01, we move them to 0.05, which we are dispensing from our pharmacy. So 0.05, definitely there is a significant change in the pupillary size. 0.01, very negligible. It's very, very less. I mean, you can measure and see that there is a slight increase, but it probably is not clinically significant and it has not affected their near vision. But 0.05, children do often complain of glare. 0.01, again, some children in the first 2 weeks will complain of a bit of glare, especially as we are always directly asking them. But after a couple of weeks, none of them have ever actually mentioned. So you give twice a day, morning, evening, or you give it after 5 minutes or something as, as
morning, evening. Ones who are not responding, then I put them on twice daily and then I shift them to 0.05. That's what I've been doing. Most of them have been responding to twice daily. So I've not moved them to 0.05 because it warrants them to come and pick it up from the pharmacy every time. So.
I do agree. We have also tried twice a day. I think it works better. It's not that, though the series is not that much. And 0.05, why don't you? I think 0.01, when it came to India, we were the first one to introduce in the form of myopin by Apasami Associates, long time back, 5 years back. I think if we give the rights, I think we can release it in no time. Because you are still holding it in RP Center, Dr. Rohit, 0.05. Why don't
0.05, not currently approved. So we have to actually inform, take consent, and then provide. There is a multi-centric trial ongoing in India on 0.01 versus 0.05. And we hope that within less than a year now, we should get results. And if it is showing better efficacy, I'm sure they would be able to get regulatory approval and it will become available as commercially available drops. Unfortunately, like I said, because this is an off-label use of 0.05, it's not an approved concentration at the moment. So it becomes a challenge to give it at the moment. So
I think both Intone as well as Apasami have 0.05 available, I think, for research purposes, not really.
Yeah, exactly. So they can provide you for research purposes, but I mean, it is the user responsibility. Intone, I believe, even exports it in markets that have possibilities.
Yeah, I think both these companies, I have seen their vials.
Yes.
Not commercially available yet.
Yeah, at the moment, yes. We hope that studies come in.
Yeah, any patients complaining of headache with DIMS? I have had 2-3 patients came back saying headache.
I've had one patient complain of moderate headache, which kind of resolved, subsided. So at the moment, I have not had any patient who
discontinued.
To continue. Yeah, who we had to
one of my did continue and went back to single vision glasses, but was wondering.
Gangadhar Sundar, the myopia capital, Singapore. Do you try DIMS or do you try weak atropine?
I think the standard of care has been atropine, like Dr. Rohit Saxena mentioned. Anybody who progresses rapidly, here the criteria is 0.75 to 1 diopter, more than 0.75 to 1 diopter per year. The default is 0.01. That is commercially available, but the stronger concentrations are handcrafted within our local pharmacies. In terms of the other spectacle modalities, they are quite expensive. And especially when there is progression of myopia and you're changing sometimes glasses every year, every 9 months, that becomes very prohibitive. So there's a lot of bias amongst pediatric ophthalmologists. Some people believe in it, that the cost is justified. Some people believe the cost is not justified. There's a high applicability of orthokeratology, and like Dr. Rohit mentioned, we ophthalmologists abhor it, but the optometrists and the parents are the ones who mainly drive orthokeratology and we do see occasionally complications from it.
I think parents, it's driven by parents because you don't need to wear glasses if you are below a certain point, say 6 diopters or less. You can get rid of glasses for the daytime, and that's probably the drive from the parents come from. Soumya, may I request Dr. Soumya now to start her presentation on newer updates on amblyopia therapy. Soumya is a consultant pediatric ophthalmologist at Shankara Group of Hospitals. She's based in Bangalore, and she has had a lot of work done in strabismus as well as amblyopia. Welcome, Dr. Soumya.
Thank you, ma'am. At the outset, I would like to thank the Aios and the ASPOs for the invite. Thank you, ma'am, for the invite again. This session is very titled very beautifully. What I did differently in 2022 with respect to amblyopia that I will be speaking on. My talk would basically comprise of understanding what are the newer understanding in amblyopia, what are the improvised tools and diagnosis, our own innovation here in terms of Kanna photo screener using the AI technology, the newer methods of treatment, our work in binocular therapy, and a few of the theses work which are in the pipeline. So the newer understanding is basically that we now know that the amblyopia is a binocular disorder, not a monocular disorder, and the intact binocular processes are not lost, but they are just suppressed in amblyopia. So it basically is a functional monocularity rather than a structural monocularity in case of amblyopes. It goes on to say that the degree of neuroplasticity persists well beyond the sensitive period as we thought earlier, and that can be restored. So what are the improvised tools and diagnosis? Primarily for diagnosing amblyopia, you need to pick up the amblyopia risk factors in terms of either strabismus or in terms of refractive error or media opacity. The newer thing in the block is the blink vision screener, which basically is based on the birefringent property of the Henle's layer. And the rays of light which comes back reflected from the Henle's layer would have a specific frequency versus those which come from the parafoveal area, and thus can pick up microstrabismus in these patients, and thus pick up the amblyopia risk factors in terms of amblyopia. The ones who have designed this also claim that even in case of refractive errors, that these prove better as photo screener compared to the those based on infrared rays. Well, our own work on this field has been the deep learning and the image processing based on image processing analysis, basically uses a smart and combines the phase and detect both the refractive errors using corneal light reflex, the media opacities in terms of dim illumination with the red reflex alteration, based on these data points which are there. So we looked at this as a photo screening device, use the same thing for validating the instrument in nearly 654 patients, which gave us a sensitivity of around 83% and 94% of specificity. All the factors, though we had done this work a little earlier than COVID. So we had used a 2013 2019. We had difficulty in picking up isometropic amblyopia and
what happened? Power cut there?
You're muted, Dr. Soumya.
Not able to hear you.
You're on mute.
am I audible now?
Now we can hear you.
Yeah. Sorry about that. So we have this. So we have the Kanna photo screener for detecting the amblyopia, and then we have the various therapeutic approaches which are now on the block in terms of either binocular therapy or the environmental influences. So perception.
Looks like Soumya is having
some issue with the net today.
Yeah, you can share your screen. Yeah.
actually good. Can you see my screen now?
No, it shows that you have started screen sharing, but we can't see your screen as yet.
I think she can
It's not visible.
summarize orally. The slides are not coming. Because you just summarize. Now it has come.
Okay.
Yeah.
So
Yeah, go to slideshow. Go to slideshow.
So yeah, that's okay now.
Yeah, okay. But your screen is still, you have to do a slideshow. Yeah, go ahead.
Okay, it's not. Okay. So the principle based on action of lateral inhibition or the rule of based cognitive learning. There are a lot of criticism against the perceptual learning in terms of what is gained on the screen is translated into the novel situation or into the criteria. And the need for home-based training system again limits perceptual learning. Unlike the binocular therapy, where it could be based on anti-perception therapy, where you use the stimulus only for the ambient eye and not use any stimulus for the
Somaya, can you kind of stop your video camera and then see?
Yes, ma'am.
No, you switch off your camera and see.
Yeah, ma'am. I'll just stop the video and see. Yeah.
It might work better.
Yeah.
Yeah. Screen is not visible. Yeah. Okay, screen is visible now. You can work.
Sure. It can be based on dioptic therapy, Aios system, or a virtual reality headset, so balanced binocular viewing, or monocular fixation in binocular field, or a passive binocular therapy. Dioptic therapy, it can work either at the cortical level or elevating suppression or by the contrast attenuation, unlike the Aios system, which is basically based on using shutter glasses, which kind of alternate at such a high speed that it gives an enriched image only to the amblyopic eye. We've got various studies which have looked at various aspects of it. What we know, there's no level 1 or level 2 evidence telling that there is definite improvement in the sensory status using a binocular therapy. And there are also challenges in terms of age included, the types of amblyopia included in various studies, and the need for more engaging games, and what happens to the visual acuity post-cessation. The implication is also that whatever improvement is seen in the stereo acuity does not correlate with the intraocular visual acuity difference. So probably the stereo acuity gain is not exactly working in the terms of improving the visual acuity per se itself. What our experience has been that we did a thesis work on this using a dioptic therapy with a monocular fixation in binocular field, taking into consideration only in anisometropic amblyopes between 8 to 40 years of age. They did a gaming duration of around 30 minutes a day, 7 days a week for around 42 sittings. We also looked at not just the visual acuity, but also at contrast and visual sensitivity. This is basically the matching patterns which is used for as a part of binocular vision therapy in a visual prime, which is basically another device of VTS. When we looked at the number of subjects, we had more anisohyperope amblyopes because we had excluded most of the mixed combination mixed amblyopic group. We found a significant improvement in both distance visual acuity and near visual acuity. What was also interesting was the contrast sensitivity in the amblyopic eye also improved with time, and the stereo acuity again improved. But there was again no correlation between the stereo acuity and the visual acuity improvement which we saw. We had a little challenges in terms of patients we were lost for follow-up because in between the COVID, so we couldn't get up as to when they stopped the treatment, what happened to the visual acuity. With whatever limited data that we are aware of, in those patients, there was no regression of the therapy or regression of the visual acuity improvement post-op visual therapy. What is in pipeline? There's a recent study which is published from China, which talks about asynchronous it's something like an IBED therapy itself. The experimental drugs either targeting the excitatory or inhibitory synapses or neuromodulatory systems, or those which look at HDAC inhibitors as well. Or the environmental changes, the recent study which has been published on transient dark exposure, especially in mice, and they looked at neural activity post dark exposure. There is 7 days of dark exposure and looked at the neural network, which can be done in live mice itself, and found that the new neural networks have been re-established. So that may be something that could be tried, or the next thing. But we are looking at software which is based on virtual reality in amblyopia. This is one of our optometry college faculty's topic research work that she is doing on. This is based on both the things, that we have combined a monocular fixation and a binocular field. This is basically the first 10 seconds of the game where the child uses the virtual headset, and any Android phone can use this software, where the amblyopic eye is used or stimulated with this grading pattern, what you see, which correlates with the visual acuity or the pre-existing visual acuity of the patient per se. After this 10 seconds, it switches to the dioptic mode, where the contrast sensitivity between the amblyopic and the non-amblyopic eye is utilized for stimulation. And the last 10 seconds again switches back to this. So they play around, and this alternation, they play around 20 minutes a day, 6 days a week for the next 3 months, and then look at the visual acuity improvement. So where do we stand now? We don't have an exact answer for what is a perfect photo screener, with the infrared photo screeners working well for a refractive amblyopic risk factors, and the other is like a blink photo screener or an easy photo screener for microstrabismus. Do we use binocular therapy or a primary or a GIM modality? What is the timing? What is the optimal duration? Does it apply to all types of amblyopia, especially in terms of sensitive deprivation amblyopia, where we don't have answers yet? Dose response relationship or individual variability. So again, there's no level 1 evidence to say that this can be used as a substitute, but definitely yes, in those of adult patients that are resistant to treatment or refractory to treatment can be a useful modality. So to conclude, explore the numerous ways to get rid of laziness, either in terms of penalty, patching, or gaming. We are near, yet so far from saying paradise lost and paradise regained. Thank you very much for the opportunity. Apologize for on and off.
Do you try this age-old anti-suppression exercise on a synapse 4, wherein the cones are supposed to be stimulated by the Heidegger?
Yes, I've seen that you use that very often during our fellowship, but we've not been using it here, sir.
I have been using both the topic treatment and also the anti-suppression exercise, and also penalization if it is a unilateral amblyopia, and also patching part-time, and also all put together. Gene therapy, so multi-pronged attack. Army, Navy, and
Everything works and nothing works both at the same time. I think it depends on the type of amblyopia. I think anisomyopia responds to almost anything, and mixed mechanism amblyopias don't respond very favorably to anything. It's a time. But now there are far more options available for mild to moderate amblyopes, which were, I think 2022, we have worked a lot on binocular therapies. And that's probably the take-home message is, if patching is not working or not happening, you can definitely look at other things. Video game-based, dioptics, software-based, virtual reality. There are now a lot more options available which were not there, say, 10 years ago. Thank you, Soumya. And may I now move to Dr. Gangadhar Sundar to give his talk on what's happening in oculoplastics and orbital. Dr. Gangadhar is in National University Hospital, Singapore. He is primarily an orbit and oculoplastic surgeon, but also does a lot of work in pediatric oculoplasty, and we will all benefit by his.
Thank you, Sumita, and thanks to Team Aios and APSPOS for your kind invitation. I still feel I'm part of Shankara Nethralaya, your team, and I recall the wonderful days that we've spent together. I'm glad this relationship continues, and thanks to Dr. Subendran also for the kind invite. We are talking about what we did in 2022 in 2023, which are today, and a lot of it has come back because of need and necessity and creativity and patient demands and hospital requirements as such. But to talk about oculoplastics, there's a very fine line between oculoplastics and pediatric ophthalmology. In fact, a significant proportion of patients are children, not just from Singapore, but the region as well, going all the way to Russia, actually. And that itself lends itself to a lot of challenges because sometimes we are not able to actively monitor these patients. And again, we see lid lacrimal orbit as different pathologies that oftentimes there's a continuum between the two. So what are the things that really changed during the COVID period, which is what we're implementing 21, 22, and going forward, is increasing use of telemedicine. We are doing more and more outpatient sedations for procedures. You're talking about Botox and a GA. Now we're doing a lot of procedures in the outpatient sedations, including laser therapies for retinoblastomas, orbital injections, and even minor biopsies and chalazion procedures. We're also adopting many minimally invasive procedures, given the COVID era, to more pinpoint surgeries. And given the increase in trauma, some innovations in implants. So that's what I'm going to talk about today. These are my disclosures, but more importantly, acknowledgements to my team, which stimulates us to do more for our patients. So look at pediatric oculoplastics. They can be classified into lid, lacrimal, and orbital disorders. And these are the following conditions that I'm going to touch upon what we have been changing recently. Simple common condition is chalazion. Yes, when it's persistent, you have to remove them under general anesthesia. But with the advent of transconjunctival blocks, we flip the eyelid like we do with transconjunctival injections for, say, severe allergic conjunctivitis, even in the clinic, in cooperative patients or in the sedation, we are now able to do a lot of these procedures, which we were not able to do in the past. So it's one innovation that post-COVID we started doing, outpatient procedures and the sedation itself. The second thing about eyelid conditions is the congenital ptosis, or I like to call it developmental ptosis. Yes, a lot of things have changed and a lot of things, basic principles haven't really changed. And there are numerous varieties of ptosis, and we have seen patients being mismanaged because of faulty diagnosis of shortcuts to diagnosis and management of pediatric ptosis. The principles remain the same, but one of the things important to bear in mind is we're talking about indications and threshold for intervention is the concept of age of awareness. The age when a child becomes aware of it, even if it's not visually significant, is the age at which we intervene. So the traditional teaching was, if you have good levator function, we did levator advancement. Moderate levator function was levator resection. Poor levator function, we were uniformly doing frontalis suspension, whether it's temporizing or permanent procedures. We used to use a lot of frontalis suspension with autologous fasciolata in the past, but I've not done for several years with the advent of other alloplastic materials like silicone rod, where we were making incisions in the forehead and the mid-forehead and the suprabrow region. But what we have now evolved towards is even no incision procedures, whereby it just takes a 5-10 minute procedure where without any incisions in the lip crease or the brow or the forehead, you're now able to correct these ptosis procedures. What is really making a comeback is bell bottom in fashion industry. Likewise, we are seeing frontalis muscle flap techniques for poor congenital, poor levator function, congenital ptosis, and even an acquired ptosis, where either in a combination with levator resection or frontalis suspension alone, we are starting to do that more. So if you stay in the business long enough, old techniques will come back around. Anything new on lid lacerations? Not much really, but the good old principles and values is important. In the past, patients used to go for centers of excellence, but if you look at patients like these who have trauma lacerations managed from these fighting accidents, you realize we have done a lot of iatrogenic trauma by poor bicanalical intubation techniques with an exposed Prolene suture rubbing against the cornea and the conjunctiva. So just a take-home message from lid canalicular lacerations, we get anatomically correct layer closure, as we were all taught in medical school and residency and fellowship days. One single procedure can give you without any residual deformity, lifelong, wonderful, functional and aesthetic outcomes. Quickly going to touch upon what is new in lacrimal disorders itself. We used to see both congenital and functional nasolacrimal duct obstructions causing significant symptoms in these kids who are otherwise either homebound or back at school and having difficulty with functioning. One of the things we started doing more and more is even pediatric office nasal endoscopy. We used to think that we can't do this in children. We can do it only in adults, where we do that and we're able to do a good endonasal evaluation and tailor treatment for them. Traditional treatment of congenital NLD obstruction is everything that you see here, but we are incorporating more and more of ELDRs, endoluminal lacrimal duct recanalizations, and balloon dacryoplasties with dacryendoscopy, avoiding the really need for pediatric DCR, even at much older children. So these are the thresholds we intervene. We don't wait for the traditional 12 months, 15 months, 18 months to intervene. Anytime the patients fail conservative treatment for 6 months or so, we go ahead and intervene in these children. Here's an example of dacryendoscopy in this child with chronic dacryocystitis. This is about 8-9-year-old child who otherwise would have required a DCR, where we're doing a dacryendoscopy, identifying an obstruction at the middle or the lower part of the nasolacrimal duct, recanalize these tear ducts, and thus giving functional outcomes and good quality of life. A good adjuvant to these ELDRs are balloon dacryloplasties, which we do in the theater settings, where we use a 5mm catheter for children more than 3 to 4 years of age, as we do for adults. So the volume of DCRs actually really go down, or the indications for DCR really go down. There's a classic example of a child who had a bilateral NLD obstructions, who has chronically managed till about 5, 6 years of age. He was ridiculed at school for chronic hearing discharge and recurrent infections, absenteeism, low self-esteem, where we have done an ELDR with balloon dacryloplasty on the right side and an endoscopic DCR on the left side. Good satisfactory functional and psychological outcomes. So quickly in the next several minutes, I'm going to touch base on a few conditions that we treat in orbital disorders in children. You know the entire spectrum of it. We have both tumor and tumor-like conditions. One of the things we did see in COVID era, and I think even in India, they published a lot of cases, was increased trauma with a lot of free time, kids running away from the home, lack of supervision, or the children left with their fathers at home when the mothers were really working elsewhere. We saw a lot of pediatric ocular and orbital injuries itself. So we all know the principles and mechanisms, and a lot of the take-home message is that a lot of these were misdiagnosed, mismanaged with the following: head injury. They have CT scan of the brain, a flow fracture is missed, as in this child that you see down below. Unless the child was asked to look up, you don't realize motility limitation, where a CT scan was even misread as no fracture because there's no bony deformity, but you can see the inferior rectus trapped, which requires an absolute early intervention. So we cannot do forced suction in children, but what is different now we do in children is, apart from the conventional CT scan, which involves an admission, sometimes sedation, cost, and high ionizing radiation exposure, as we talked about in the oculoplastic session yesterday, we're using more and more cone beam CT scan, which gives only 10% of the exposure of ionizing radiation compared to conventional CT scans. So we're using this both in children and adults for our patients. The other innovation that we're doing more and more for our children are the use of bioresorbable implants, earlier diagnosis, lower threshold for intervention, and earlier intervention. As you can see in this child over here who has scans at the top, which shows a floor fracture repair, which has been done with a bioresorbable implant. The same patient, same scan, but 18 months later shows a complete healing of the bone, complete resorption of the bioresorbable implant without any implant-related complications. More commonly seen in children is roof fractures, which again is often missed and usually not intervened upon, where again, we go through the upper lip crease approach, reduce the roof fracture, put a bioresorbable implant, and lo and behold, 18 months later, the roof is healed very well without any residual complications from permanent implants you put in place. You don't need a craniotomy approach for these patients. In the last couple of minutes, I'm going to touch about tumor and tumor-like conditions. We are all familiar with the ISPA classifications and tumors and vascular malformations. Again, diagnosis is very important. Right terminology is important so that you can avoid right interventions. In the past, we were giving a lot of intralesional steroids, but again, now we are starting to do more and more oral propranolol treatment with near complete regression of these lesions. So that's something that can be managed with telemedicine, where the child does not have to come in, even if they're living in countries nearby. What else about veno-lymphatic malformations? We moved away from observation to disastrous surgery, as we used to do in the past, to intralesional sclerotherapy with bleomycin and a few other sclerosins. But again, with telemedicine, again, we're using more and more mTOR inhibitors. This is our classical management in the past, where we are now able to use these patients, where we're prescribing sirolimus. Patient can be overseas, can have an MRI done every 3 to 4 months to 6 months, show regression of lesion, clinical progression can be monitored without necessarily coming in for various procedures. A quick advancement in the field of Langerhans cell histiocytosis is a child who could not even walk, had to stay at home, was walking with a limp, where we are now using BRAF inhibitors, imifeminib for LCH, multifocal LCH, with good outcomes, as you can see in this child, who was able to go back to school and play, and you can see regression of these lesions. No talk is complete without touching on retinoblastoma. In the past, they say they live to see, and I think that's full credit goes to Santosh Manawar for really radically changing the way we are diagnosing and managing retinoblastoma, salvaging a lot of these eyes. But I believe that we should go one step further. Apart from them seeing, they should look normal, and I'm a strong believer of socket rehabilitation for these children. As you can see in this child, where we used to remove a lot of eyes, we don't remove so many eyes with the advent of IAC. However, cases like these tell us that when you have bilateral multifocal tumors, and I used to see children where bilateral enucleations were done, where there's no intraarterial chemotherapy to salvage the eyes, these are children who are referred as a one-eyed status, Even a passport photograph shows something like this, where with the advent of IAC, we are able to chemo reduce these tumors, treat with local therapy. But sometimes patients cannot come from far away for intraarterial chemotherapy and they have to stop treatment. And hence, it's a failure of treatment, not because the parents are not willing, but they just can't afford it. So I give full credit to Santosh once again for writing this beautiful editorial in the most recent issue of IJO, where I think we need to build a global consortium, cut down costs so that we can deliver more for our patients with less interventions and less technology itself. So in conclusion, I think pediatric oculoplastics, the awareness has to increase both amongst GPs, pediatricians, and pediatric ophthalmologists and ophthalmologists alike. Early referral to centers of excellence, where you refer to or whom you refer to, makes a big difference in outcomes, so that the appropriate intervention is given the first time around. I'm a strong believer of multidisciplinary approaches, and we need to build such like this forum, national, regional, and global consortia. And I give big thanks to my team, which makes this all possible. Thank you very much.
Thank you, Gangadhar Sudhar. Thank you. Next speaker, we are running short of time.
We'll welcome Dr. Bhami Hariprasad Shenoy, a very good friend of mine, my roommate at LVP and my senior. He's at Manchester now. He did his fellowship at LV Prasad, as I said. Hari, welcome to the symposium, and I would invite you to start your talk.
Thanks. I'm just trying to share my presentation. I'm just not able to. Have I got?
Can we invite the next speaker so that you can?
Yeah, that's fine. Yeah.
Okay. May I request Dr. Bharti to start her talk while Hari can get ready. Dr. Shenoy can. Bharti, can you share your screen, please?
Sure. You see my screen, okay?
Yes.
Yeah, perfect. All right, thank you so much for giving me this opportunity. I'm very thankful to Aios and ASPOS both, and then my close friend Sumita for giving me this invitation. So I'll be talking about pediatric cataract, what I've been doing different in 2022. And since then, I have no financial disclosure, but we were a site for Trivia Therapeutics, and you'll know why I'm mentioning this at this point. So what I did differently, I was trying to think. So I have broken it down into little subheadings: pre-op evaluation, the IOL power calculation, and then the surgical technique, how it has differed in the past year. So starting with pre-op, so I had this 22-month-old boy who was referred for evaluation of bilateral cataract diagnosed by his pediatrician. He was otherwise healthy, full-term baby. Mom had, so family history was significant for mom being recently diagnosed with cataracts, and she was told it was kind of a congenital cataract, but she has had no surgery. She's in her 30s, and then grandmother had her surgeries in 50s, and mom is pregnant at this time, and she is really worried, what's the chance of my second child having the cataract too? And since we all know it is transmitted autosomal dominant. So you can see at bilateral cataracts, left greater than right. So maybe they were hereditary cataracts. I didn't really know. So mom really wanted like testing to investigate what we should do. So as we all know, for unilateral cataracts, we don't need any pre-op testing or evaluation because it is believed to be from localized dysgenesis in the eye. For bilateral cataract, I would say half of the patients we can identify some cause. They either have some known syndrome, genetic mutation, treatment for cancer, steroid treatment, something that you can attribute to be responsible for bilateral cataract. But then comes the hereditary cataract, where there would be some family member. I would say about 20-25% they are hereditary cataracts, and rest are probably idiopathic, which in our study was about 35%. So now we have an option of some genetic testing available for these patients. And as I said, these bilateral idiopathic are the one that needs systemic evaluation. And then the hereditary, if the family is really interested, we could offer a genetic testing for them. So we do a complete pediatric physical exam. We do send some labs. So in US, we do have like a basic newborn screening, which screens for about 30 metabolic disorders. So we just go through them and make sure there's nothing that's positive out there that was missed. We do check for glucose, basic metabolic profile. Probably top titers are going to be important in the Asia Pacific region, which we don't encounter so much in US. And then we do refer to genetics if the family was interested. So we were part of this trial called Behind the Blur Early Onset Bilateral Cataract Genetic Test Program. So they have a kit that basically tests for 66 genes. So this was basically offered to the acquired cataracts. It was free for us just because we were part of the trial, but it is commercially available too. And I'm going to let you know how we can access that. There is a congenital cataract panel, which can test for 41 genes. If the onset is unclear, then there's a comprehensive cataract panel, which tests for about 171 genes. And then there's an anterior segment dysgenesis panel, if you notice microphthalmia or anterior segment dysgenesis. So we usually order it through the preventive genetics. I have no financial disclosure, but that's how we offer. And most of these are somewhere from $800 to $1,200, but we usually submit it to the insurance companies, and many of these, if you give them a letter of medical necessity, they do get covered. And then the way they are tested is we basically collect the blood, saliva, or buccal mucosa. Once you fill out the form online, they usually ship it to the family or directly to the physician. And then the turnaround time is about a month. So that's something new that we have been doing in the pre-op evaluation. Coming to IOL power calculation, as we all know, for younger children, we do biometry under anesthesia, but anybody who can sit behind the IOL master, I still prefer IOL master. As we all know, it's much more reliable. There's better fixation, better numbers out there. And then we undercorrect depending on the age at surgery. But we can still see how much myopic shift happens. This was from one of our study that was published of about 200 patients over a long follow-up of 20-25 years. So we tried to understand it better. So we studied our normative patients and then studied the biometry, because there have been no studies since Gordon and Donzis. And then we compared them with the cataract size. And then we were trying to understand what will be the implications on post-op target and IOL power selection. As we all know, the age and the axial length, they probably matter, and we already follow the undercorrection criteria depending on age at surgery. We typically aim for emetropia around 6 to 7 years of age. But in this study, we did find that the steeper keratometry was also a contributing factor for myopic progression. So we did add a little more undercorrection for patients who had steeper keratometry less than 42.25. So that's a new change we have done. And this is the table from our paper out there. The other new thing that we have been doing is there were a couple of studies last year showing the efficacy of Barrett Universal 2 formula, which is widely used in the adult population, but it has been shown to be more predictable in our pediatric population, showing a smaller absolute prediction error. So that's the other additional thing that we have been trying. We have the new IOL Master, which gives us the option versus there are online Barrett calculators, which you can access, and then you just feed in the information online. It doesn't save any information, but you can print out your copy. The only additional thing it still needs is white to white distance, length, thickness, ACD, predict the refractive error, and then the K and axial length as we normally do. We don't have our data yet, but we have been studying it in the past year. For the surgical technique, I think there has not been much changes in the technique itself. What we usually do is use vitrectorexis in very young children up to age 2. Anybody after age 2 gets a manual ACCC. Probably we have evolved that because we have a lot of fellows that are trained with us. We do have primary management of posterior capsule and vitreous in first 6 to 7 years of life. closed chamber technique, bimanual techniques, viscoelastic, good cohesive viscoelastic is a must. We do use a little bit of visco just to protect that endothelium because they have a long life to live. And then very important to close all those wounds in pediatric population. So this was an interesting boy who came in, like he's a 7-year-old boy who was referred for his right eye cataract surgery. He has history of glasses since age 3, anisometropic amblyopia, patching, atropine, penalization. He was diagnosed with cataract in past year and a half, but it had progressed. That's how he was referred. He did so on further questioning. When I dilated the pupil, it looked very unusual kind of cataract. I did question more. So he did have history of trauma, which he endorsed on the medial side of his right eyebrow, but then it didn't require any suturing or anything for him. So when I took him for surgery, as you can see, what we usually do is we do 2 side port incisions, and then we do the rhexis using the intraocular forceps. And then when we usually use the vitrectome and then irrigation port, and then try to separate that lens material in all the quadrants, as you can see. And then finally we went towards that quadrant where you can see that little I thought it might be a posterior capsule plaque, but you can see once we pulled it out, there was a pre-existing defect right there. So probably this was a congenital cataract. He was referred as a traumatic cataract. And then we injected the viscoat right there to seal that area. We could aspirate rest of the lens material, did a good vitrectomy, and then inserted the lens. You can see we inserted it through the nasal aspect. So we didn't want the leading haptic going in that posterior capsule opening there. So that's how we opened up the nasal aspect and injected the IOL, probably the basic principle that we all would use. But looking back, I would think I hadn't expected a pre-existing defect in this one. What I would have done differently was probably aspirated all the lens material before going in that quadrant and pulling it out. This was probably a little more stressful for us because there was a big opening right there. We were really worried that the lens material might drop. This was another kid, 14-month-old, very complicated medical history, referred for bilateral mature cataracts. He was a patient of mine with no cataracts, and within a month he developed like those mature cataracts. Again, we used the same technique, but because he was a young child, he did need primary management of posterior capsule. So what we usually do is we use a trocar right at the beginning of the surgery. We insert that trocar, and then we finish the front part of the surgery. So what we did was did the vitrectorexis, remove the lens material, put the IOL in. As you can see, the IOL is already in there. And then we go through that side port incision through that trocar, and then with the irrigation port in the anterior chamber, and then usually do the posterior capsulorhexis and the vitrectomy. We think it's a safer technique just because we have fellows, so we know the IOL is in the back before we go to the back. But this kid, you can see once. So what I did was close the incision partly so it doesn't allow too much of fluid leakage, and then we went and did the PCC, and then we were trying to do the vitrectomy. That's when you can see the eye is really getting softer and softer, which was very unusual. You can see those folds forming near that trocar as if the globe is kind of collapsing. I was really concerned, so we somehow finished the vitrectomy because we were really worried about it, and then pulled it out, but probably what was happening was we didn't remove the viscoelastic from the anterior chamber before we did that, and there was little viscoat and lot of provisc sitting there, so it didn't allow the fluid to go to the back. So that's the reason there was an imbalance between the irrigation and aspiration that was happening. So there was not enough irrigation, and we were aspirating the stuff out, which probably caused the collapse. We did check his retina at the end. There was no retinal detachment. We put an air in, we sutured it well. Next day, the IOP was 15, but that time it was like really soft globe, which was kind of scary for us. So that's what I have changed. I usually aspirate the lens material, put some pre-placed sutures, and then go in and do the vitrectomy. We do use intracameral moxifloxacin at the end of the procedure. The other new thing that we have started doing is we used to use the subconj DEXA for a very long time. We have switched to intracameral DEXA for all these patients. It's a preservative free. We have been using intracameral triesence at the end of surgery, about 4 milligram, 0.1 ml. So this way we give lower frequency of eye drops to the family, especially useful for kids with cerebral palsy or developmental delays, where it could be very challenging to get the drops in the eyes. We have been involved with this trial with Dextenza, which is dexamethasone intracanalicular implant. So basically, you can see the picture right there. What we do is dilate the punctum. We insert that dexamethasone insert there and leave it there. So once you make sure you dry it before we put it in. So once you put it in, it kind of swells with the moisture and then fits comfortably and securely in there. It releases steroid for about 30 days and then reabsorbs and exits the canaliculus without the need for removal. The only thing is the cost factor. It's pretty expensive. It's about $600 for us. So we have been using it as part of the trial. If given an option, probably I would still go with Triesence. With that small amount, it's usually helpful and it's much more cheaper for us. So these are some of the changes we have made in the past year. Thank you so much again for giving me this opportunity.
Thank you.
Thank you. Share. Okay.
Dr. Shinoy, are you ready? Yeah. Thank you. Please go ahead. We are running a little short of time. So if there is time permits, we will have some discussion. Go ahead, please.
Okay, can you hear me?
Yes.
Yes.
We can see your slides.
Okay,
also.
so thank you to Sumit and other organizers. Good to see Akshay, who was my roommate. I'm going to talk about what I did differently in the past year in terms of ophthalmic imaging, which is my special interest. And I'm going to present some of the cases to explain what, to demonstrate what we did differently. I have no financial interest because I'm going to talk about loads of equipment. As I said, this is a case-based discussion. I'm going to show you how we used these modalities in a different manner to help our patients. So case one is a 6-year-old female referred to me by the optometrist because they couldn't improve their vision with glasses. The vision was reduced at 0.6 logmar in the right and 0.46 in the left eye. This is the multicolor. This is what you get on a Heidelberg when you image them. And you can see that there are some amount of disturbances over there. 6-year-old girl, not sure what's happening. So we get a fundus autofluorescence done, and you can see that very clearly those hyper autofluorescent specks. These are very classic of Stargardt's disease. So we get a genetic testing done, and the child does have Stargardt disease. So it's a quick turnaround for the child. There's the diagnosis, and then we can put in support in place as they need extra support in school. Next case patient is a 12-year-old female referred to me again with reduced central vision and some macular changes. If you clearly see on these fundus imaging, you can see those macular changes there, and some RP, pigmentary changes over there. So we get a fundus autofluorescence, and you can see the kind of difference. You see the enormity of this lesion actually, which was not seen on fundus imaging, but on autofluorescence you can see those classical hyper autofluorescent dots and hypo autofluorescent inside. And this is classic of a Best's disease. So we do a genetic testing. And the key is that in Best disease, the fundus autofluorescence is always more prominent than the fundoscopic examination. So if you have very early Best, if you do a fundus autofluorescence, you can get a better view of their lesion. Case 3 is a 16-year-old girl referred with problem with night vision. The fundus picture, as anybody could guess, this is typical of retinitis pigmentosa, bony spicules there, waxy pallor, attenuated blood vessels. So this looks like an early retinitis pigmentosa on this picture, but some difference over there. But this is the fundus autofluorescence. So this actually is a very advanced retinitis pigmentosa. You can see the amount of changes of what it's seen on a fundus autofluorescence, what you couldn't see classically on the normal fundus examination. And what I want to explain is about this hyper autofluorescent ring. This is a ring that is present between the viable retina, which is within this ring, And this is all non-viable retina. All these are already gone. So this child has got an extremely constricted field. Just based on fundus autofluorescence, you can know that. And this is only viable retina that is functioning. So this genetic testing did confirm the retinitis pigmentosa. So I have superimposed the Heidelberg OCT on the fundus autofluorescence. And you can see that this is the ring, this is the edge of the ring, and this is the viable retina there. And you can see the photoreceptor all damaged over there outside the ring. So this is the only viable retina, which again is confirmed on electrodiagnostic testing. You can see that this retina is fine. All of this is non-viable. The hyperautofluorescent ring can be at the junction of viable and non-viable retina, but the viable retina can be outside the ring, as in this case, where this is a macular dystrophy, probably in North Carolina. You can see that there is a nice ring there, but the viable retina is outside the ring, whereas in retinitis pigmentosa, the viable retina will be inside the ring. Of course, fundus autofluorescence is helpful in cases of drusen. Some buried drusen, you can see it very clearly. This is superficial drusen again, which it shows. The next patient is a 13-year-old male referred by optician, as he was seeing dark patches in his central vision in the right eye. His vision was slightly down, but on examination, I could see only a subtle change. This is the optomap, autofluorescence. You can see that maybe something going on there, not very clear. This is the OCT. You can see the Aios junction being disrupted slightly there. And if I zoom in on the fundus over there on the macula, you can see some amount of lesion there. But very subtle changes that was seen. We got a Heidelberg autofluorescence because the optomap and the Heidelberg use different wavelengths. The optomap is green reflectance and the Heidelberg is blue reflectance. So they do show different lesions differently. But I couldn't see much of a changes. So what we did was we got infrared imaging on Heidelberg, and you can now see that lesion, characteristic lesion, what is seen in a handheld laser-induced trauma, accidental damage due to handheld laser, and the child parents did gift him one. And these commercial ones on eBay and Amazon are probably sometimes even 100 watt, which is a medical grade, but these pointers are all illegal. So you can see that characteristic lesion with one lesion there and a line there. This is probably due to the pain where the child has moved his eye, and you can see that line. These vertical line originate from the RPE and they go into the photoreceptor. So you get this classical lesion. You may not see this is an old lesion. It will show up only on an infrared reflectance rather than on your regular fundus autofluorescence. This was also shown in a paper here. You can see that blue reflectance, what is seen in an Heidelberg, green reflectance seen in an optomap, doesn't show this lesion, which is seen on the multicolor of the Heidelberg. And if you look at the infrared reflectance, it clearly delineates the lesion. These are old lesions, which can be seen better on infrared. When it's early lesions, probably you can see it on green or blue reflectance. So this is another utility of infrared or near or red reflectance. Case 5 is a 7-year-old with NF1. As we all know that these individuals can get iris nodules, that's least nodule, but they can also get choroidal nodules. So these choroidal nodules are not very easy to see. Sometimes they don't have a least nodule, but if you do an infrared or near infrared red light imaging, you can see these choroidal nodules so clearly. So this child didn't have a least nodule, but they showed up very nice choroidal nodules on infrared, and they are they may be more prone for developing optic pathway glioma, so they would need to be imaged from the MRI point of view. Case 6 is a 12-year-old female, light sensitivity and nystagmus from birth. Visual acuity was reduced to 1 logMAR, that's 660 vision. This is the multicolor with the fundus autofluorescence. You can see those lesions there. And when you do an OCT, this is a classical foveal cavitation. Foveal cavitation can be classically seen in achromatopsia. So we did a gene testing and that proved achromatopsia for this, but they can also be seen in other conditions mentioned here. You can sometimes see them in cone dystrophy with supernormal rod ERG or vitelliform macular dystrophy, Stargardt's, and sometimes even in solar retinopathy, etc. But that foveal cavitation is most characteristic of achromatopsia. So that was what, and when they got light sensitivity, it's more of a cone dysfunction. Case 7 is a 5-year-old female with NF1, which is low risk. Patient was supposed to be low risk. They were not yet had MRI. The parents have been always, really anxious. We have been monitoring them in the clinic. We've not found any lesion nodules, and this is the first time that they got a OCT scan. And we have started doing something called a macular volume scan on TopCon. This is just a software modulation, and you will get the inner retinal layer thickness, that is the ganglion cell layer, nerve fiber layer, and it will be demonstrated as a red lesion like that. So this patient had a normal macula, but on a volume scan, even the disc was okay. This is a Caucasian child. You can see those volume scans showing these lesions, and we got a MRI scan because they have this lesion on the OCT, and they were found to have an optic pathway glioma. My last case is a 6-month-old male presented to us with nystagmus, some light sensitivity, but anti-segment was normal, no iris transillumination, no other problems. So we did a handheld OCT, which we use a lot, and the handheld OCT showed a foveal hypoplasia. So there was no other signs of albinism. So we were suspecting an SLC38A8 mutation, which causes crossed asymmetry on VEP, no albinism, and they get foveal hypoplasia with congenital nystagmus. So this child had that condition, and that was easy. We didn't waste time on doing other things. Otherwise, they may be investigated for congenital nystagmus. Handled OCT at 6 months of age, genetic testing in another 6 months. At 1 year of age, we had a diagnosis for this child. This is what I've been doing differently in the past year. I want to acknowledge my genetic colleague Aios for some of the cases that we have co-managed and some of the nice images, and Vinod, who's my other colleague, for some of the cases that we have co-managed. Thank you very much.
Thank you.
Sumita, Dr. Surendran sir, good evening, and Sumita, thank you. Thank you, sir, for organizing this symposium for the Aios.
If you don't mind, another, it's only 5:25 now. Another
Yes.
10 minutes, I think we'll be able to finish 2 speakers.
Perfect, sir. No
Yes,
problem.
10
No problem. So you are muted, Sumita, you are muted.
I said yes.
Thanks for the wonderful.
Some technical difficulties, so we are a little delayed.
And
Sorry.
these 2 papers, 5 minutes each.
That's okay, no problem.
So next speaker is Dr. Preeti. She is going to update on neuro-ophthalmology. Preeti, please share your slides.
Yep. Can you hear me and see the slides as well?
Go ahead.
Yeah.
Thank you so much for the opportunity. I know we're running a little short of time, so I will try and get through this quickly. At the outset, I just wanted to say that a part of this research is supported by a grant from the Buncher Foundation from Pittsburgh. So this is something new we've done in the last year or two, is starting sort of a dedicated study clinic for patients with CVI or cortical visual impairment. The initial part of the presentation really was about what is CVI. I'm going to skip that a little bit because I think most of us are fairly aware. I'll just quickly mention that it is the leading diagnosis for visual impairment in children under the age of 3. And as we all know, it's a large spectrum, including poor vision, complex visual processing issues, field defects, facial and space recognition issues, etc. And some of these children can actually have very good visual acuity, but have some higher processing issues, and so are often difficult to diagnose. The commonest cause is perinatal or postnatal hypoxia or hypoxic ischemic encephalopathy. Other causes include trauma, infections, metabolic and genetic causes, seizures, etc. This was a little bit about the pathophysiology of CVI. I think I will skip this in the interest of time. I was going to talk a little bit about the dorsal and ventral streams. They're basically the 2 streams that are supposed to sort of complement the primary visual cortex in our understanding of visual processing. So I'm just going to skip this a little bit. The diagnosis of CVI is fairly a clinical diagnosis. It's a lot to do with you looking at the child, talking to the parent, and a very detailed history taking. There are several caregiver questionnaires that can assess, that can assess various aspects of visual functioning. One of the common ones used is something called the Insight questionnaire that was developed by Dr. Dutton in the UK. There's another 12-question short questionnaire and the CVI range, which was invented by Dr. Lansky in the United States. A complete ophthalmic exam, obviously, the visual field assessment, electrophysiology, and neuroimaging. A little bit about the Insight inventory. It has 52 questions which refer to visual, perceptual, and motor difficulties. It's divided across 6 domains. So it's visual search, visual fields, visual attention, perception and movement, visual guidance of movement, recognition, and navigation. And then there are questions asked, and the caregiver will rate from 0 to 4 based on never to always. The way the questionnaire is designed is based on your answers. It can come up at the end with a tailored strategy based on the answers that the caregiver gave. The CVI range is an assessment tool used to determine the degree of CVI on a scale from 0 to 10, where 0 is no detectable vision and 10 is vision comparable to a typical sighted peer. In addition, of course, the assessor's observation of the child and interviews with the parents are used to come up with a rating. There are 2 ratings, rating 1 and rating 2. Rating 1 determines the extent to which the CVI interferes with functional vision. And rating 2 again looks at certain specific characteristics like color, movement, visual preferences, latency, etc., and comes up with a combined score. Again, like I said, score is from 0 to 10. 0 to 3 is phase 1, which is most severe. 7 to 10 is as close to typical visual functioning as you can. So what we did differently was trying to set up the CVI study clinic where the children with suspected to have CVI would have a complete evaluation with an ophthalmologist. Typically, I do the exams for all of these kids. We have a teacher for the visually impaired who comes in once a month and does the Insights questionnaire and the CVI range. We have an electrophysiologist. All of these children get a VEP and an ERG. And then we also review the neuroimaging with our neuroradiology team. The clinical exam, again, assessing visual behavior, various tests to determine vision based on the age of the child, a complete eye exam, ocular motility exam, specific attention being given to nystagmus and strabismus, accommodation and convergence, and then, of course, a cycloplegic refraction. These were just some clinical pictures of what we might see in these children. The ones on top are a child with CVI with small pale optic nerves. And then below we see a larger optic nerve with significant cupping. This is often referred to as pseudoglaucomatous cupping. This is not really glaucoma, but you can see these in children with PVL or periventricular leukomalacia. A little bit about the electrophysiology role. It's really useful in young infants who are not able to comply with behavioral testing. We typically do this to also check if there's any other cause for decreased visual function, such as a retinal cause. We do a full field ERG, a pattern ERG, where possible sweep VEPs, and then transient VEPs. We also sometimes employ multi-channel recordings of transient VEPs to identify if there is generalized dysfunction versus a unilateral dysfunction, which might be seen with hemianopias. We can also look for chiasmal dysfunction here. This is just an example of a pattern reversal VEP. The first one, this one here, if you can see my arrow, is a normal response to the various checker sizes, 50, 25, and 12.5. And then here is in a 4-month-old with CVI. And you can see as the checker sizes go down, the VPs get degraded, both in the amplitude and latency of the P100. A little bit about our initial analysis. We have, this was a few months ago, we have a little more now, but this is 28 patients. The mean age was 5.89. We were able to formally assess visual acuity in about half of them, so 53. About 1/3 have nystagmus, half have strabismus, and close to half have an abnormal VEP and optic nerve pallor. The average score on the CVI assessment was 5.79, and it ranged from about 2.5 to 7.75. We also looked at our subset of children 5 years and younger because there's very little data on the use of the range in that age group. And the average score was similar, 5.86. We looked at also the presence of nystagmus and strabismus and then tried to relate it with certain subdomains within the CVI range. And we found, as intuitively we can, this would probably make sense, is that children with nystagmus seem to have increased visual latency. They have field preferences and also more difficulty with visual guided reach and distance and spatial orientation. So that was significant. We've also tried to look at the two questionnaires, range versus the insight. And here we've plotted on the y-axis is the insight and the x is the range. And we found that certain domains, especially the visual perception and visual recognition, have a pretty good correlation. So the two questionnaires also seem to be looking at similar things, although they were designed in a totally different format, but they give us, they sort of point us in the same direction. So in summary, the idea is to have a comprehensive evaluation of all aspects of CVI and then come up with individual plans for rehab and interventions in these children, coordination with parents and other services for the child. And we're hoping in the end to be able to collect data to correlate what we find clinically with what a teacher for the visually impaired might find with all these assessments, and then come up with sort of a classification that will help us better understand CVI. Thank you.
Thank you, Preeti. That was an excellent presentation. Really enjoyed it. I would like you to share this presentation to me for more details.
Absolutely.
But sorry, we are running out of time. Ekta, may I ask you to go ahead with your presentation? Dr. Ekta was a vitreoretinal surgeon at Shankar Netralaya, and now she is a instructor in charge of electrophysiology at Nebraska, University of Nebraska. And I welcome Ekta to give this talk.
Thank you, Dr. Sumita and Aios. Can you see my screen?
Yes. May I ask you to wrap it up as soon as possible?
Yes, please. I'm just quickly going to a patient this is a teenage boy who was referred with some mottling of the retina, and basically on the OCT, the referral physician found some cystic spaces on the OCT. Now, once we did the detailed electrophysiology, we found that the photopic as well as scotopic responses were significantly reduced, and there was a negative B wave on the ERG. Even a more detailed testing of pattern ERG and photopic negative responses were reduced. So this patient ultimately had mucopolysaccharidosis type 3, that is a Sanfilippo syndrome. So this was just to illustrate the wide battery of tests which are now available. And electrooculogram looks at the retinal pigment epithelium. We do ERG and MFERG, which is looking at more of the inner retina. But now what we have is more of pattern ERG and PHNR, which is photopic negative response, which can even look at the ganglion cells. For the children, ICIF has given 5 protocols, and it's important for children to have fixation, to have multifocal ERG, pattern ERG, and electrooculogram. And there is a newer protocol called GOSH protocol, which is with a reduced timing, just 5 minutes of dark adaptation, which is now being tested in children, and it has found to have equivalent result to ICIF standard protocol. And this is being employed in many European countries. So what we know about the development of ERG is like the light adapted responses, they are the first to mature, but the dark adapted responses take almost 10 years to reach the adult size. Electrooculogram, we all know about the Arden's ratio. So we have gone much beyond the vitelliform degeneration, and now we have its application in acquired diseases like azure, quinine toxicity, and birdshot chorioretinopathy. So the Arden's ratio is basically reduced. This is another patient with autosomal dominant vitelliform degeneration where the Arden's ratio is reduced, and it proved to be genetically best one mutation. When we come to full-field ERG, going beyond the normal A and B wave, which tests the first order neuron, that is the photoreceptor and the bipolar cell, the interest is into the now the inner retina, which is the ganglion cell. And for that, we need a pattern ERG or a photopic negative response. So for the kids, it's important to have a dark adapted intense flash. That is, we need more brighter flashes. And this has some more usability in children. Another type of dark adapted response, which is a red flash, is very important, as it also gives us a function of cones, which comes in the form of an X wave, and then the B wave, which is a rod response. So this is important to diagnose cone dystrophies and achromatopsia. And it has a very important use in vitamin A deficiency, where the rods are first gone, but the X wave is still retained. Electronegative B wave is basically B by A ratio less than 1. And this is one of the patients where you can see at the macula some cystic spaces seen. This is on the OCT. And if you look at the ERG, there is a reduction in the dark responses, the scotopic responses, but the B by A wave ratio is 0.97, which is less than 1. So this is X-linked retinoschisis. Another vitamin A deficiency patient. Again, there is almost extinguished B wave. This is a patient with the corneal clouding in the left eye. You can see the fundus image is not well seen. There is some pigmentary change, which is non-specifically seen on the retina, and with some scetic spaces on the retina. But if you look it on ultrasound, there is a thickened choroid sclera junction and the widened optic nerve. So this patient had so much of visual field loss. The patient had electronegative B wave. So this forced us to do further testing. And this patient was found to have a mucopolysaccharidosis type 1, which is a Hurler-Scheie syndrome. So when we are talking about B wave, negative B wave, it's also important to know the importance of on and off bipolar cells, because in a complete congenital stationary night blindness, only the on pathway is gone. But in an incomplete pathway, both on and off bipolar cells, they are dysfunctional. So how do we test that? So this is a newer protocol, photopic on-off ERG, which can detect the B wave and the D wave. The B wave is for the on bipolar responses and D wave is for the off bipolar responses. So this is one patient who had a light sensitivity from childhood. You can see a bullseye maculopathy-like lesion. The patient had a CDHR1 mutation, which is for cone rod dystrophy. And looking at the ERG, you can see extensive reduction in the photopic responses. But there is also a reduced on and off ERG response, which is because the cones are responsible, they get signals to both the on and off pathways. Another important modality is pattern ERG, which tests the central retina, which is with a pattern. And there is a P50 response and there is a negative N95 response. So this is important to differentiate a maculopathy from an optic nerve disease. So N95 reduction is prognostically responsible for the optic nerve disease, and it is a late change. If it is reduced, it does not improve. So it also can help us in functional overlays. There are small and large fields which can be tested 15 degree and 30 degree, and which can basically test, if you can see, this is a achromatopsia, which is a smaller, just central defect. And here the 15 degree, central 15 degree will be abnormal. But this is a patient with Joubert syndrome, where the periphery is abnormal, but the center is functional. So these are two protocols of pattern ERG which can be tested. This is just, it can be lost in Wolfram syndrome, which has an optic atrophy. And this is a patient with Wolfram syndrome where there is a reduced light flicker and there is a reduced P100 amplitude and increased latency. So for the, I will be skipping them fast. And there is also an interest in transient smartphone blindness, like patient can present with a monocular vision loss with increased visualization of the smartphone and the ERGB wave is reduced. VEPs, basically, what is new is like we have laid more stress on pattern reversal. The pattern onset, offset VEPs are important for children who have nystagmus because not with fixation, we can do a better recording with that. Another is a sweep VEP, which can help in visual acuity assessment. So we start doing that as well. So this is a patient with optic neuritis where you can see on pattern VEP, the P100 waveform is basically, amplitude is also reduced and it is delayed. But look at the pattern ERG where the N95 waveform is also reduced. Another patient with autosomal dominant optic atrophy. And once you look at the pattern ERG, N95 is reduced in both the eyes. Albinism can have a misrouting of the optical chiasm, and this can be tested by a multi-channel VEP. And this is pretty useful. So I'm just skipping that. Now, this is a patient who came with no visual complaints, but had some pigmentary changes. And this was found to have a USH2A mutation, which is an Usher's mutation. But this patient was found to have no auditory complaints and hearing was normal. So this was basically an extinguished ERG, which forced us to do the genetic testing. And this was a non-syndromic Usher mutation. This is a 6-year-old girl who was a carrier of albinism. The father had basically albinism.
Ekta, can you just wrap up? I think
yes.
We have taken 15 minutes extra. Sorry that we were the last speaker.
I'm just skipping. So this patient basically had an asymmetrical VEP, which is because of the misrouting. ERG is now important in diabetics. There's another photopic negative response, which gives us some idea about the retinal ganglion cells. And there are so many publications which have come, but it is very important in early diagnosis of glaucoma. Migraine has supernormal responses. There is also interest in autism, schizophrenia, because of the neural pathways that ERG can help. Enhanced S-cone syndrome, where there is a S-cone protocol which can be done, and the S-cones are enhanced, and L and M cones are missing. Even there is an enhanced response in Huntington's disease. But COVID is something which helped us, we got so many manifestations during the last year with retinal ischemia and, outer retinal and inner retinal damage. And there was a reduced photopic and scotopic responses and extensively reduced pattern ERG and photopic negative response, which never recovered.
Dr. Ekta, I think conclusion. Thank you.
Yeah. So thank you so much.
Thank one and all, and welcome back to Shankar Netra.
Thank you.
Thanks, Dr. Sumita.
Thank you, Dr. Surendran, for all your help.
Yeah.
And Rohit and
only the team, I think.
I can see everybody here.
God bless.
And, Aios has been trying its best to, rope in as many societies as possible. And thanks to all the efforts of Namrata Sharma that this time we could get on board more than 20 international bodies. And I am personally very thankful to all the participants here. And all of us, I think, will grow richer by hearing each other. Hi, Ganga, how are you?
Hi, Lalit bhai. You got a different name, Namrata Sharma, under your thing. So it looks like she's overbearing you. Nice to see you, Lalit. Yeah.
No. Very, very nice to see, I was hearing a couple of presentations here, but obviously since it's outside my scope of subject, so therefore intermittently I was hearing. In any case, Dr. Surendran, thanks a lot. Rashmi, everybody else. Rohit, taking out time for. Yeah, thanks so much.
Thank you, Aios, Asia Pacific Society, for a wonderful session.
Thank you. Thank you so much, sir.
Thank you. Thank you so much. Hi, Namrata, and hi, Dr. Lalit.
Nice to see Naveen and Rashmin and a few other superstars as well. Hi, guys. Bye.
Yeah, the next society also has a lot of superstars.
Yeah.
So we have some great superstars from US joining us.
Yeah. So when Dr. Surendran said we are running late, I said, doesn't matter. It is your own friends who are, behind you. They will wait.
Yeah.
I'll take leave, guys. Thank you very much. I'll see you all in either Kuala Lumpur or Kochi.
Surely.
Yes.
Bye.
So thank you, Aios, for giving us the opportunity to hold this international conclave. And of course, I have some great speakers from US and of course, participants from leading centers from all over India. So welcome, Dr. Michael Dettolo, Dr. Padmaja Sudhakar, Dr. Sachin Kedar, and Dr. Sangeeta Khanna, who woken up pretty early in the morning to join us. And of course, the Aios president, Dr. Naveen Jaikumar, Dr. Ambika, Dr. Rashmin, and all my colleagues here at in the Aios Society for being here. And I hope we can move forward for a great meeting. Dr. Naveen, if you would say a few words to start off, and then we'll start the symposium.
Thank you, Rohit. Basically, very, very pleased that Aios has been able to partner this year with AIOS for this event. And we have a great set of speakers. I think almost everything focused on afferent disease and the disc and things like that. So it's going to be a nice session, and I hope everyone enjoys it. Over to you.
Dr. Rashmin, I would request you to your first few opening words, and then we'll start to introduce the first speaker.
Thank you, Rohit, and thank you, Dr. Lalit Verma, Dr. Namrata Sharma, and the entire team at Aios. It's really a pleasure, and Aios is really fortunate that we have this very interesting session that is lined up here. May I invite Dr. Naveen Jaikumar, the president of Indian Neuro-Ophthalmic Society. He's our first speaker. He's going to talk about visual fields. Dr. Naveen is from Chennai. He was one of the early practitioners of the art of neuro-ophthalmology at Shankar Nethralaya, and I think is mentor to a lot of us here present here. Dr. Naveen, all yours.
Yeah, thank you. I'm just a sec. Sorry, I'm a little difficulty here. Just a second. Rashmin?
Sir.
Yeah. Yeah. Can you just give me a minute, please? I'll just get organized. For some reason, the Zoom is, yeah. Okay. Can you see my screen?
We got you. Yeah. Yes.
All good? Okay.
Yes, all good.
Thank you. For some reason, it's showing the last slide first. Okay, here we go. So thank you all, and welcome to this first session. And Yeah. So I'm going to talk on visual fields, and I just have 6 quick lessons and couple of interesting visual fields for you to look at, and finally one plan on how to localize defects. Now, this kind of a visual field is probably the best known to everyone, and it doesn't need any further thinking except to say that this is a bitemporal hemianopia caused by a pituitary tumor. I'd like you to take a look at this field, however, which is of a patient who complained of sudden onset of difficulty in seeing in his left eye, and this is the left field. So if you look at this, sometimes it may be confusing. What kind of a pattern is this? This is the left field. Is it something in the retina or the optic nerve? But things will look a lot more clearer, and the picture emerges in a much better way if we look at the opposite field as well. So if you see the field of the right eye now, you can very, very clearly see an exquisitely congruous, incomplete left homonymous hemianopia due to this particular occipital infarct in the right occipital lobe. So the message here, number one, is always perform fields for both eyes, irrespective of which eye the patient is complaining about. Let's move on to this particular field. And before you tell me you're showing me a field of only one eye, let me tell you that the left visual field of this particular patient is normal. And how do we know that this is the right field? Because this is roughly where the blind spot would be. So here you see a pattern which is like an upper temporal defect in the right field, but spilling over the vertical meridian. Interestingly, if you look at the fundus of this patient, you can see that he has a chorioretinal scar following an injury, and the pattern of that scar and the defect perfectly correlates with the visual field that you see here. So a quick message here is sometimes unilateral field defects, etc. Just look inside the eye. There may be a corresponding fundus lesion to match this particular defect. What about this? So this is quite simple. Here you can see other optic nerve defects, which I'll quickly go through. Central scotoma and centrocecal scotoma. These fields belong to a patient who had optic neuritis and went into a postneuritic optic atrophy. And although his vision was about 612, he had those little defects there as well. Here you see a field which is predominantly an inferior altitudinally flavored field, although there is some amount of sparing just below the macula there. And this is classic ischemic optic neuropathy. You can see that the superior pale disc edema correlates perfectly with the inferior altitudinal / arcuate defect that you see here. Okay. How about now this field? Now, you may tell me like, oh my God, why are you showing another bitemporal hemianopia all over again? But wait a minute, what's wrong with the blind spots? They seem to be in the wrong place. So it's important. Let's look at this in a slightly different perspective. Let's move these around. And you can now see that this is the right field and that is the left field on the opposite side. Now they're facing you directly. And this is not a bitemporal hemianopia. This is a binasal hemianopia. So always lesson 2, view the fields as if you are the patient, okay? Place the right field printout on your right, the left field printout on your left, and then look at it, and then you will not get confused. So most of the time, binasal hemianopia, although there are intracranial causes, many of the causes are ocular, like optic neuropathies, retinoschisis, etc. Right, take a look at this field. This is a patient who had poor vision in the left eye. As you can see, the left field is generally depressed. But take a look at the right field with a normal visual acuity, and you can see in the extreme upper temporal corner of this 30-degree field, a small defect which seems to be respecting the vertical meridian. So in a unilateral optic neuropathy, here is lesson number 3. The neurologically more important field is that of the contralateral eye, the apparently normal eye. This particular patient had a junctional scotoma. As you remember, they have the peripheral nasal fibers crossing on the opposite side that produces this field defect, which is peripheral in nature. not central, it starts peripherally, which brings me to my next lesson, which is that central 30-degree strategy. It's good for almost all neuro-ophthalmic defects, but you can miss a junctional scotoma if it is early and starting off in the periphery, and you'll pick it up only much later when it comes into the central field. Okay, now we have defects which are on the homonymous side, in this case on the left side in both eyes. So these are homonymous hemianopias, but look at the pattern. They are not a quadrant, they are not a complete homonymous, they're incomplete, but they fall into this kind of a sector. So these are sector anopias. This is a left sector anopia due to a right lateral geniculate body lesion. So sector anopias normally associated with LGB lesions, and incomplete homonymous hemianopia, here comes lesson number 5. Incomplete homonymous hemianopias can be localized to different regions of the post-chiasmal visual pathway. If you have a complete homonymous hemianopia on one side, all you can say is it's a retrochiasmal lesion on the opposite side, but you can't say whether it is LGB or radiations or cortex. But if it's incomplete, you can glean some more information from that field. Lateral geniculate body lesions have these peculiar shapes of sector anopias because they have two different circulations. One is the anterior choroidal artery from the middle cerebral artery, and the other one is the PCA circulation. So just like you saw a sector anopia, you can have defects which are missing that sector, but affecting the other sectors above and below. So these are 4 areas involved. So this is known as a quadruple sector anopia. So this is again due to an LGB lesion in this particular patient. Here now we have quadrantopias. This is a superior quadrantopia, commonly described as a pie in the sky. And this is due to a temporal lobe lesion, the Mayer's lobe, the inferior radiations. Conversely, if the superior radiations were involved, so this is the patient who had a temporal occipital infarction. Conversely, as I said, if the superior radiation, the parietal lobe lesions were involved, you get a pie on the floor, like you see in this particular patient. And this patient had a thalamoparietal hematoma. So my lesson 6 is, as far as confrontation fields is concerned, always perform confrontation fields, especially when you have poor visual acuity and formal fields cannot be performed. You can also do color confrontation using a red target. And let me tell you that bitemporal hemidystromatopsia, a dullness of a red on the temporal hemifields, is as significant clinically as a bitemporal hemianopia. And lastly, you can actually make diagnosis of hemi-neglect syndromes in left homonymous hemianopias particularly. So I'm going to show you this particular patient who had a left homonymous hemianopia. So what he's saying is he can see on the right field. So he can't see anything from the left side. So the examiner is going to do a confrontation field here. As you can see, he can see the right finger, but he cannot make out the left finger because it's on the hemianopic side. So what the examiner is doing is moving it to the intact right hemifield, and now he's doing the same thing. See what happens when he presents both targets simultaneously. So the patient is able to see separately, but when simultaneously presented, he ignores the finger on the left. So this is a left hemi neglect due to parietal lobe lesions. I'm going to end my talk with a quick algorithm on how to manage. So let's take, you have done fields for a patient, place them in the right way, right field in front of your right eye, left field in front of your left eye, and then ask yourself this question: is it a unilateral field defect or is it a bilateral defect? If it's a unilateral defect, it's usually retina and optic nerve related. So look within the eye and check the optic nerve. But if it's bilateral, ask yourself if it's respecting the vertical meridian. If it's respecting the vertical meridian, if it's not respecting the vertical meridian, once again, it might be in the retina or the optic nerve, but always consider the possibility of a junctional scotoma as well. If it is clearly respecting the vertical meridian, then we are dealing with a hemianopia, in which case ask yourself, is it homonymous or is it a heteronymous hemianopia? Heteronymous hemianopias come in 2 flavors, bitemporal and binasal. Bitemporal is always in the chiasm. Binasal can be in the chiasm, but don't forget to look at the retina and optic nerve as well. And sometimes these may be congenital as well. Now, if it's homonymous, is it complete or is it an incomplete? Does it involve the entire hemifield or is it involving only part of that hemifield? Now, if it's involving the entire hemifield, if it's a complete homonymous hemianopia, it's a non-localizing retrochiasmal lesion on the opposite side. It could be optic tract, LGB, radiations, or cortex. But if it is incomplete, as I showed you, if it's incongruous, it could be an optic tract lesion or a laterogenic late body lesion. If it's forming into sector anopias, it could be an LGB lesion. If it's congruous, it could be optic radiations. Quadrantopias can be pie in the sky and pie on the floor, depending on which radiations are involved. And if you have perfectly congruous defects, then you're dealing with the occipital cortex. Thank you very much for your attention.
Thank you, Dr. Naveen, for that very interesting yet very concise take on visual fields. I also invite at this point, I would like to welcome Dr. S. Ambika, who is the Vice President of Aios. Dr. Ambika, are you here? Would you like to give a comment or any other suggestion? Dr. Goel?
Yes, Dr. Rashmin. Just I wanted to emphasize one thing, that if there is a central field defect in one eye, then we should always consider either optic neuritis or optic neuropathy unilateral. But if there are central scotoma in both eyes, then we should always think of toxic optic neuropathy or nutritional optic neuropathy, because that will give rise to central scotoma in both eyes. So that is one of the things. And secondly, I wanted to emphasize that centrocecal scotoma, if they are there, then we should think of optic disc pit with central CSR also, in addition to the toxic amblyopia. So, and I was not aware of later geniculate body sectranopia, which he has mentioned very nicely.
Thank you. Thank you, Dr. Goel.
Okay, thank you.
Any other comments from any other panelists?
Hi.
Hi, Dr. Ambika.
Ambika.
Here, she's the Vice President of Aios. Yes, Dr. Ambika.
How frequently you see peripheral field loss in neuro-ophthalmic diseases? And how do you document them?
Well, if it's peripheral field loss, I think most neuro-ophthalmic diseases do present in the central 30-2. As far as the peripheral field loss is concerned, unless you're looking at certain toxic conditions or amblyopia, or say, let's, for example, optic perineuritis, one would conceivably expect a peripheral field loss. The other thing which would be missed in a central 30-2 would be, for example, a ring scotoma, which we used to see earlier in early retinitis pigmentosa. But I think by and large, I think a central 30-2 is sufficient, but always be on guard. As I told you, I'm always suspicious of any field defect in the temporal quadrants. And that's, I think, useful to keep that in mind.
One thing I want to emphasize is that in neuro-ophthalmology, field defects, they always approach to the center. So central 30-2, that is the usual field charting for all neuro-ophthalmological fields also. And even in as you were saying, that a peripheral field defect, upper temporal region, or the temporal junctional scotoma, they also are indicated in the central 30-2 also. They come there also.
Thank you. I just want to know that is there any conditions where we can miss, because we see a lot of paraneoplastic patients, and when they come with advanced vision loss and field loss, they do have not that much of clinical fundus clues, but peripheral field loss, because couple of patients we had as a progressive visual field loss, like an acquired RP-like picture. So ultimately it turned out to be a cancer-associated retinopathy, where initial field loss was more of a peripheral type of field loss, which we were not able to pick up in the early phases. So that is the reason why I asked that by and large in an unexplained vision loss, would you like to add any other field analysis apart from 30-2?
Yes, of course. I mean, definitely, I would possibly consider doing a 120 screening as well. And in these kinds of cases, when there's some unexplained vision problem with an apparently normal-looking field, I think doing electrophysiology is also helpful.
Yeah.
If there are any further comments, if there are no comments, then we'll yes, Sachin.
So I think I would add two other conditions that can start with peripheral field defects for a neuro-ophthalmologist. So Dr. Dattila will discuss this later. Papilledema, untreated, will start with peripheral visual field constriction and then start going inwards unless it's fulminant. And also consider the unilateral temporal defects that you get from anterior occipital lobe lesions of any kind. So I think at Emory, what we do is we start with 30-2 unless we strongly suspect peripheral field defects, in which case we go on to do Goldman visual fields. And Dr. Ambika alluded to retinitis, cancer-associated retinitis. So if we clinically suspect it, then we will bring the patient back for Goldman. But by and large, we start with automated visual fields.
I would possibly add one thing conversely, that sometimes you have patients who are complaining of some problem in their vision, difficulty in seeing on one side, and the 30-2 looks kind of all right. And the 120 looks fine as well. In those cases, when I'm a little suspicious, actually I do a 10-2, basically magnify that central area and just see. You never know whether you might find some little hemiscotoma or something which will point you to some small occipital lobe lesion.
I just wanted to add that we actually use a 24-2 instead of a 30-2 just because it's more efficient and less fatigue, and it covers the temporal 30 anyway. So we haven't, I don't know if there's a formal comparison between the two, but that's what we practically do.
One question I wanted to ask, anybody any experience on 24-2C and how well it works in neuro-ophthalmology?
Once again, as I told you, that 24-2C might probably help in the kind of situation I was talking about, where someone is complaining of a vision problem, but otherwise the field is looking all right on a 30-2. I don't know, but I would probably do a 30-2 or a 25-2 straight away and then go and look at a 10-2. So I don't have any personal experience of a 24-2C. I wonder whether anyone else has.
No, we never.
Right. I will move on and maybe come back for discussion a little later in the program. So now I'll invite Dr. Mike Dattilo from Atlanta. Dr. Dattilo joined, he's a faculty at Emory Eye Institute in Atlanta, and he's going to talk about papilledema and Aios. Dr. Mike.
Thank you very much, and thank you for the invitation today to speak. Let me just share my screen here. Can everyone see my screen?
Yeah.
Yes.
Okay, great. So thank you again. I'm going to talk about papilledema and idiopathic intracranial hypertension. I'm going to try to move fairly quickly in the interest of time. In talking about papilledema and idiopathic intracranial hypertension, first we need to, I have no financial disclosures. First we need to define what is papilledema. So by looking at fundus photographs, sometimes it's very difficult to determine if optic discs are swollen due to papilledema, especially if you have a scenario like this where you have only one eye, no clinical history, you know nothing about the patient. Artificial intelligence programs have become very good at identifying papilledema from non-papilledema, but as a clinician, without any other information, I would be hard pressed to determine whether these optic discs were from papilledema or from some other cause of optic disc edema. In fact, none of these are from papilledema. They're all swollen optic nerves from various causes. We have ischemia, compression, and infectious and non-infectious inflammatory optic neuropathies. So papilledema, just as to define the term, is optic disc edema due solely to elevated intracranial pressure. Now that we have a working definition for papilledema, does papilledema equal idiopathic intracranial hypertension? Well, the obvious answer is no. There are multiple causes that are multiple things that can cause papilledema, such as infections, inflammatory conditions, compressive conditions. And there are a number of etiologies for each of these causes. I've listed some here just for reference purposes, such as meningeal inflammation from bacterial meningitis, idiopathic or inflammatory meningeal inflammation. Intracranial space occupying lesions are the ones that we're probably more concerned about than most other things. Meningiomas invading the venous sinus system. All of these can cause elevated intracranial pressure and papilledema. Idiopathic intracranial hypertension, however, is slightly different because, unfortunately, we don't know what the underlying cause for idiopathic intracranial hypertension is. So I don't know if I can accurately define what is idiopathic intracranial hypertension, but we can kind of describe what it is. And it's a syndrome of elevated intracranial pressure of unknown etiology. It's usually seen in women in their childbearing ages, and it's associated with changes in weight, either with being overweight or with a recent weight gain. The incidence reported for idiopathic intracranial hypertension in the general population is low. It's 1 in 100,000, but it increases 3 to 4-fold in an appropriate demographic, usually in the overweight population. Unfortunately, due to the obesity epidemic that's currently ongoing, we can see here a trend in obesity in the United States in adults, and it's predicted that by 2030, 50% of the adult US population will be overweight. Idiopathic intracranial hypertension, the incidence of it is mirroring this obesity trend. So we expect to see a lot more cases of idiopathic intracranial hypertension in the near future. So just to talk a little bit about idiopathic intracranial hypertension, the symptoms of this disorder are headaches. You can also get transient visual obscurations, which is depicted by the cartoon on the right, which is really graying or blacking out of the vision as someone changes head position, usually to a more dependent position, as if they're bending over. You also get pulsatile tinnitus or pulse synchronous tinnitus. So in case people are unaware of what that sounds like to a patient, I have this short audio clip here, which will so to kind of give you an idea of what patients are experiencing when they complain of pulsatile tinnitus or pulse synchronous tinnitus, and also double vision. And we're going to come back a little bit to double vision in a second. All of these symptoms are concerning to the patients, but they don't cause any serious or pose any serious medical concerns in that they don't cause any permanent physical dysfunction. However, once we get into the signs of idiopathic intracranial hypertension, particularly papilledema, which you can see here from one of my patients who had very severe papilledema in this 35-year-old woman who was morbidly obese, papilledema can lead to severe and permanent vision loss. Some of the other signs of idiopathic intracranial hypertension, as I mentioned, are a cranial nerve palsy, with a sixth nerve palsy being the most common. There have been reports in the literature of other cranial nerve palsies, such as cranial nerve 4, 5, 7, dysfunction related to elevated intracranial pressure, but by far the most common is a sixth nerve palsy. As Dr. Kadar mentioned, there are also visual field changes that can be seen in idiopathic intracranial hypertension, but usually the visual function is fairly well preserved, with normal visual acuity, normal color vision, and essentially normal visual fields. However, the visual field defects that are commonly seen in idiopathic intracranial hypertension or with papilledema are an enlarged blind spot or a nasal depression. The nasal depression is one of the more common visual field defects. With progressive and continued swelling of the optic nerves, though, you can eventually get severe constriction of the visual fields where people are only seeing out of really the central vision in each eye. In these cases, the visual acuity can still be relatively normal. And then another sign of elevated intracranial pressure, not specific to idiopathic intracranial hypertension, are radiographic changes And this is from a paper that we published at Emory in 2021, just depicting some of the signs seen radiographically associated with elevated intracranial pressure. We can see a partially empty or empty cella, cerebellar tonsillar ectopia, enlargement of Meckel's cave where cranial nerve 5 traverses through, meningoencephalocele and basal encephalocele. These are can be somewhat associated with an increased incidence of seizures, and actually we're looking into that association now as one of our current research projects. Vertical tortuosity of the optic nerve is also seen with chronically elevated intracranial pressure, as well as posterior flattening of the globe. You can see protrusion of the optic nerve head into the globe in these axial slices, as well as perioptic CSF space. Enhancement of the optic nerves in idiopathic intracranial hypertension is would basically disclude the diagnosis, with the exception of right at the optic nerve head, just from the stasis of CSF there. And you can see venous sinus stenosis bilaterally, which you can determine by this nice little slow taper of the venous sinuses. The diagnostic criteria were revised in 2013, but essentially to make the diagnosis of idiopathic intracranial hypertension requires the presence of papilledema, elevated pressure on a lumbar puncture in the lateral decubitus position, and normal CSF studies and no alternate cause. I've shown here in this figure the diagnostic criteria, the revised diagnostic criteria by Friedman, Liu, and Degree. That was proposed in 2013. So in the top portion panel, this is what's required for a diagnosis of pseudotumor cerebri, and it includes papilledema and the other conditions that we mentioned. They do talk about a diagnosis of pseudotumor cerebri without papilledema. This is a diagnosis, however, without papilledema, we usually don't see these patients because they're not at risk for vision loss without swelling of their optic nerves from their elevated intracranial pressure. The workup really needs to rule out other causes of elevated intracranial pressure, so you would need an MRI brain, possibly an MRI orbits as well, both with and without contrast, an MRV of the head to rule out venous sinus thrombosis or any compressive lesion on the venous sinus system. And then, as I mentioned, the lumbar puncture with CSF studies. Traditionally, it's been reported that an elevated opening pressure is above 25 centimeters of water. However, recent studies have suggested that that is well within the range of what is typically seen in normal people, and that the diagnostic criteria should consider raising that bar to 30 centimeters of water. And then normal CSF studies, including cell count, glucose, protein, cytology. I always get a cryptococcal antigen as well, flow cytometry, just to rule out any potential cancerous causes, along with the cytology, and CSF cultures. In atypical cases, you can consider getting an MRA of the head. This would be really looking for a posteriorly draining carotid cavernous fistula, and also an MRI of the spine. Most relevant would be the lumbar spine, and that's depicted here sort of in this cartoon of a balloon, as the thecal sac in the lumbar region can expand to alleviate some of the intracranial pressure, some of the pressure as a pressure head. If there is something that's constricting this lumbar region and not allowing the thecal sac to expand, there's a resultant forward or upward push of pressure causing elevated intracranial pressure in those cases. And that would require a potentially different treatment than what we standardly do for idiopathic intracranial hypertension. The treatment, the gold standard treatment for idiopathic intracranial hypertension is really conservative with weight loss. And we usually recommend about a 10% weight loss, 10% of their current body weight for weight loss. As an adjunct to that, we do use medications such as acetazolamide and topiramate. And we go up to doses as high as potentially 4 grams a day for acetazolamide if necessary. Usually we start with about 500 milligrams twice a day. Topiramate is also effective at lowering intracranial pressure, as well as it's a treatment for migraines, so it may help a bit with the headaches. And as an added benefit, it also acts as an appetite suppressant, so it facilitates weight loss. In patients who are recalcitrant to medications and weight loss, or who are having progressive visual dysfunction, or who can't tolerate medications, surgical treatments are an option. They're listed here: optic nerve sheath fenestration, CSF diverting procedures such as a shunt, venous sinus stenting, and bariatric surgery. Just to say a little bit more about the last two, this is a 2022 study by Mullen et al. From Birmingham. And what they showed was, in these figures, how changes in body weight affect changes in intracranial pressure. Now, if you look down at panel C, what they have is intracranial pressure as a percentage of body weight loss. And you can see a pretty decent effect as you get into the 10% range. With, in their study, it took about 20 to 30% of body weight loss from starting point to reach an intracranial pressure that was considered within the normal range. In addition, they also looked at various types of methods of losing weight, and CWI, the blue line, just stands for community weight intervention, such as Weight Watchers or some other community-based diet. And then they had surgical procedures, and what they found were that surgical procedures, particularly gastric bypass, were most efficacious in facilitating weight loss. Moving on for a second to talk about venous sinus stenting. Now, personally, I don't have much experience with venous sinus stenting since we don't perform this very often at Emory. But in cases where neurosurgery has considered doing venous sinus stenting, they look at the trans-stent gradient, and at Emory, they use a cutoff of 8 millimeters of mercury. This study, which was recently published in 2022 in November, actually looked at various trans-stent gradient or trans-stenotic gradients. And what they found was that intervention in even a low trans-stenotic gradient of less than 4 millimeters of mercury produced a fairly robust decrease in retinal nerve fiber layer, improvement in visual fields, and decrease in papilledema and intracranial pressure, suggesting that venous sinus stenosis could be a viable option for treating idiopathic intracranial hypertension. However, there is a 2% risk of serious complications, such as migration of the stent or potentially erosion of the stent through the venous sinuses. So we do need to be cautious about the potential complications for surgical treatments that we recommend. With that, I'll end the talk, and more than happy to answer any questions.
So do you use both topiramate as well as acetazolamide together also?
I typically don't use them concurrently, mainly because of the metabolic effects and the changes in electrolytes. I do, however, occasionally use them concurrently when I'm transitioning people off of Diamox and starting them on topiramate. So I'll cut their dose of Diamox, start them on a low dose of topiramate, and then progressively decrease their Diamox if they don't tolerate Diamox or they're having severe side effects to Diamox. What I've actually found is that in a number of people who don't respond very well to Diamox, they have a pretty robust response to topiramate. And I'm moving more and more towards using that as more of a first line than Diamox.
Any side effects of topiramate do you see frequently? Anything?
The most common side effect that people complain of is severe mental fogging or mental clouding. So that is the most commonly reported from my patients, is that they really have a very hard time focusing on tasks with topiramate. So it's really a balance between efficacy and side effects. And if people can't tolerate it, then we move to other potential treatment modalities.
And your stenting of sinuses is being done by the radiologists or neurologists, or
So it's when it's done or when it's considered at Emory, it's being done by interventional neuroradiologists.
Neuroradiologist. Okay.
Oh, I'm sorry, interventional neurosurgeons. I'm sorry. So it's mainly the neurosurgeons that are doing it. And we have a couple of vascular neurosurgeons who have been on board with trying it. I haven't personally referred anyone. I don't know if Dr. Kadar has for venous sinus stenting at Emory.
Okay. Thank you.
Sachin?
I have a question to Dr. Detillo, basically, you did. It was very interesting that you mentioned topiramate as an alternative to Diamox. So my question to you would be, do you use both together or one instead of the other? How does it work for you?
So we really only have definite data for use of Diamox in idiopathic intracranial hypertension. However, there are several reports using topiramate and that have shown topiramate is potentially as effective, if not slightly more effective than Diamox in the use of idiopathic intracranial hypertension. But there haven't been any really large studies looking at it. My standard right now is to start with Diamox, and if they can't tolerate Diamox or they're not having a decent effect with Diamox, then I will consider switching them to topiramate.
Right.
I've had several patients who have had progressive worsening of their papilledema on Diamox, even on fairly high doses, up to 3-4 grams a day. And their edema has continued to get worse, and transitioning them to topiramate, even 50 milligrams twice a day, their papilledema significantly decreased, and I've transitioned them off of Diamox, and I've been able to maintain them on very low doses of topiramate. So in select people, it has very, very good efficacy. And I've been using it more and more as of late, but if you ask me, what am I still using primarily, it is Diamox.
And you reach up 4 grams a day.
Yeah. I'm sorry?
And your dose before you discard it would be up to 3 or 4 grams a day.
Usually I'll get that high if necessary. I try not to go that high because the side effects become intolerable on Diamox, essentially the brain fatigue and brain fog again. If I'm increasing the dose sequentially and the edema is continuing to worsen, I have a very low threshold for transitioning to topiramate at that point.
And what would you say is your mean Diamox dose on which you kind of feel you found most patients to kind of stabilize?
A lot of
most
patients.
average?
Yeah, a lot of patients do really, really well on 500 milligrams twice a day of the extended release. If I had to answer, most of my patients are probably somewhere around 1,000 milligrams twice a day. And then I will transition them off and start to decrease their dose once the swelling resolves, and then I'll sequentially lower it and follow them fairly closely to make sure that their edema doesn't recur.
Dr. Detillo, how frequently you follow your patients and how frequently you ask for OCT or other visual function test, and how do you follow them?
Sure. So OCTs and visual field tests I get at every follow-up appointment. And that really is a case-by-case basis. If I'm really concerned about someone, then I'll probably see them after initial evaluation in 2 to 4 weeks, depending on how concerned I am. If there's a low level of papilledema, they have normal visual function, and nothing else concerning, then I'll probably see them every 2 to 3 months. And once I know that they're stable, then I'll extend it out to every 4 months if I know that they're doing well. So typically every 4 months for my patients who I'm not very concerned about with IAH and they're doing well. And once they're off of Diamox, I'll see them usually one more time once the swelling has resolved and they're off of Diamox in like 3-4 months. If the swelling hasn't reoccurred, then I don't usually make a dedicated follow-up with them.
Thank you. Rohit, would you like to introduce the next speaker? Padmaja. You're muted. Rohit, you're muted.
Yeah, sorry. So Dr. Padmaja is very, very well known among the circles here. We have had lovely and very great interactions with her in all the previous Aios, and it's an absolute pleasure always to listen to her. She'll be talking on papilledema, pseudopapilledema, just following this wonderful talk on papilledema. So it will help us to keep disc edema in perspective and try and understand how to differentiate between the two and how to work our way around these rather important and fairly frequently presenting conditions. So Dr. Padmaja, again, a pleasure, and thank you very much for coming for this international conclave of Aios.
Good evening, for introducing me. So sorry, Dr. Saxena. I'm sorry. So so we'll be talking about pseudopapilledema. Is the disc elevation true or false? I have nothing to disclose. So the objectives.
Dr.
Padmaja, we need to see your slides. Yeah. Can you share your PPT?
We can just see the kind of list.
Are you able to see now?
Right,
there we
now
go.
we're on.
That's good. That's good.
You can go back to the first one, please.
All right. Sorry, I'm so sorry. So again, thank you very much. And we'll be talking about pseudopapilledema. Is the disc elevation true or false? I have nothing to disclose. And our objectives today would be to identify different types of pseudopapilledema and to distinguish pseudopapilledema from true disc edema. So let's start with the case. This is a 5-year-old boy who was referred to neuro-ophthalmology after identification of bilateral optic disc edema that was detected on a regular school exam. He had virtually no complaints. He's not overweight. And on exam, he's got reasonably good visual functions, maybe a little bit less visual acuity in the left eye, but no significant refractive error. And these are the fundus photographs. As you can see, the optic nerves look fairly swollen and there's no spontaneous venous pulsation. So we do an OCT, retinal nerve fiber layers obviously thickened related to the disc edema. So at this point, you want to stop and think, are we dealing with the true papilledema or is this pseudopapilledema? And I would say that is very hard to do just based on the appearance of the disc. But in this case, he already came with this mega workup, which was already done. So he's already had an MRI head and orbits, which was unremarkable. MR venogram with contrast showed hypoplasia of the right transverse sinus. Spinal tap under sedation, the opening pressure was about 18 centimeters of water with normal CSF exam. So after all this, it's easy to say, yes, this is pseudopapilledema, but in real life, these cases are very challenging. So going back to some basic definitions, so optic disc edema is swelling of the nerve fiber layer at the optic nerve head due to an optic neuropathy of any etiology. And papilledema, as we just learned, is a specific optic disc edema caused by raised intracranial pressure. And this term is frequently misused to diagnose or define optic disc edema. And pseudopapilledema is elevated appearance of the optic nerve head without edema of the nerve fiber layer. So we have to differentiate true disc edema from pseudopapilledema. This is a common clinical problem, but very, very challenging even to experienced examiners. Often patients, especially children, are noted to have the optic disc elevation during a routine exam. The diagnostic uncertainty and the alarm created by this finding overshadows the fact that the patient literally has no signs or symptoms of neurologic dysfunction. Many patients with pseudopapilledema get referred to neuro-ophthalmology after they are subjected to extensive, evaluation. So when you look at disc edema, it has many differential diagnoses. Is this papilledema? Is this an inflammatory etiology? Is this an ischemic etiology? Are we dealing with a tumor or an infiltrative process? This could be from intraocular hypotony or intracranial hypotension, and we have to keep congenital conditions like your Leber's in mind. Similarly, pseudopapilledema also happen from many optic disc abnormalities. To top the list, we have optic disc drusen, but it could be a hyperopic crowded optic nerve, a myopic tilted optic nerve. It could be Burmister's papilla, myelinated nerve fibers, vitropapillary traction, and peripapillary mass. Let's look at some types of pseudopapilledema. The first is a hyperopic eye with a short axial length who can have a congenitally small optic nerve with a crowded optic nerve head as shown in this photograph. If it's a myopic eye, they have a long axial length. The nerve can be inserted into the globe at an oblique angle. So the nasal part is relatively elevated compared to temporal, and this gives the false appearance of an optic disc swelling. Burmister's papilla is a congenital variant. It originates from an incompletely regressed hyaloid artery, which can obscure the margins of the optic nerve and give the impression of true disc edema. Myelinated nerve fibers, which result from the anomalous migration of oligodendrocytes beyond the lamina cribrosa, can produce this picture, obscure the disc margin, can be mistaken for an optic disc edema. And here we have vitreopapillary traction, where the clinical photograph shows how the margins can get blurred, and the OCT on the right also shows how it elevates such that there is a false impression of an optic disc edema. So, pseudopapilledema can also occur in many underlying genetic conditions like your Down syndrome, Algely syndrome, Kenny syndrome, even in Leber's. Now, when you have true disc edema versus pseudopapilledema, again, it's very challenging to distinguish just based on fundus appearance. You have to elicit a careful history of symptoms of raised intracranial pressure or other neurological symptoms, which will help, like your headache, transient vision loss, etc. But these features are so non-specific, and often there's a considerable overlap of headache symptoms between females with IIH and pseudopapilledema. And interestingly, optic disc drusen and IIH can coexist, especially in children. And when you see signs of neurologic dysfunction on exam and in the context of a suspicious optic nerve, it should raise concern for acquired disc edema or papilledema. Once you know it's pseudopapilledema, you must distinguish optic disc drusen from other causes of pseudopapilledema. Are there some fundus features which can help us? Yes. So if you have a true disc edema, you will have a blurred nerve fiber layer. You can see flame-shaped hemorrhages or disc hemorrhages. Vessels may be obscured. The cup may be retained or filled. You may have absent spontaneous venous pulsations. You may have dilated retinal veins. In pseudopapilledema, it's going to be no obscuration of vessels. Disc vessels should not be dilated. There may be an anomalous branching of vessels. The nerve fiber reflexes are normal. You should not see any flame-shaped hemorrhages, but you may see a subretinal hemorrhage adjacent to the disc sometimes, and the cup may be absent. Spontaneous venous pulsation is a reassuring sign that there's no raised intracranial pressure, but unfortunately, it's absent in 25% of normal and 75% of children with pseudopapilledema. So the absence of SVP is not specific to raised intracranial pressure. There are some ancillary tests that we use, like your B-scan ultrasound, fluorescein angiography, disc autofluorescence, OCT, CT of the orbit, MRI head orbit, MR venogram, contrast enhanced studies, and lumbar puncture. So the gold standard is your intravenous fluorescein angiography. This is going to show leakage from the optic nerve head if it's true disc edema, and late staining if this is pseudopapilledema. But remember, it's an invasive test. It requires IV access. You need a cooperative patient. It's not available in many clinics, and it's used only when other testing is equivocal. So these are some features of a pseudopapilledema with late staining on the fluorescein angiogram. And this is a fluorescein angiogram showing leakage in true disc edema. Again, these are imaging findings which we just discussed in the IIH lecture. So if you have an MRI showing empty cella, distension of CSF around the optic nerve, optic disc protruding into the globe. And if you see on the MRV, stenosis of the transverse sinus or a focal stenosis at the junction of transverse and sigmoid sinus, all these are signs of raised intracranial pressure. Similarly, on the MRI orbit, you may see enhancement of the optic nerve in optic neuritis and enhancement of the sheath in perineuritis. On spinal tap, you can confirm elevated intracranial pressure when it's 25 or above in adults, 28 or above in a sedated or obese child, 25 or above in a non-obese, non-sedated child. And again, the CSF analysis is going to help with identifying an inflammatory demyelinating cause. Let's talk about optic disc drusen, which is a very common cause of pseudopapilledema. These are extracellular deposits of calcium, hyaline, and other proteins, which are located posterior to the Brooks membrane, but anterior to the lamina cribrosa. The pathogenesis is that there's either altered exoplasmic flow, resulting in extrusion of drusen or degeneration of the retinal ganglion cell layer axons. You have two types of drusen. Superficial are easily visible on the disc as yellow refractile bodies. And then you have deeply buried drusen, where the drusen is deeply buried and obscured by the overlying retinal nerve fiber layer. Now, drusen can progress from being deep to becoming superficial slowly with age. So, are drusen without visual complications? Absolutely no. You can have painless, insidious vision loss unnoticed by the patient, rarely transient vision loss without raised intracranial pressure, just from transient ischemia caused by vascular compression by the drusen. They can develop NAION with acute vision loss and sometimes sequential NAION. You can have central or branch retinal artery occlusion, central retinal vein occlusion, peripapillary choroidal neovascular membrane. Now, if you do a CT for some other reason, you will incidentally pick up on the drusen as a hyperdense body at the optic nerve head. If you do a fundus fluorescein, if you do a fundus autofluorescence, which is done on an OCT or via pre-injection photos during intravenous fluorescein angiography, the superficial drusen will autofluoresce. On ultrasound, you can identify a hyper-echoic signal at the optic nerve head, which will create an acoustic shadow and a deep reduplication artifact. And the strong signal will persist even if you minimize the gain setting. Now, OCT is a very valuable tool. It cannot distinguish your true disc edema from pseudopapilledema. There are some techniques like your enhanced depth imaging OCT or the swept source OCT, visualization of the deep drusen. So drusen will appear as a hypo-reflective mass with a hyper-reflective border on EDI OCT. And this also helps to identify forms which are peripapillary hyperreflective ovoid masses that were mistaken for drusen, but now we know is a distended axon. So EDI OCT has become a very sensitive test for identifying optic disc drusen. So in conclusion, differentiating pseudopapilledema from true disc edema is not easy even for experienced examiners. Optic disc drusen in children is typically bilateral. It tends to be more buried than in adults. If you have true disc edema, it definitely mandates explorations for secondary causes of intracranial pressure or other causes of true disc edema. Optic disc drusen can occur simultaneously with IIH, especially in some children. And these ancillary tests like ultrasound and fundus autofluorescence may be helpful in distinguishing the two, but sometimes they are less sensitive for detecting buried drusen, especially in children. And that's my last slide, and I'm happy to take questions.
Thank you very much, Dr. Padmaja. Excellent coverage. And as I said, we have understood a lot about how to differentiate true and pseudo disc edema. A perfect sequential talk on the true disc edemas and papilledemas. Maybe we'll go on to the next talk, because I can see that the cornea guys are already joined, although I will inform Dr. Basak, that we got the hall almost 25 minutes late. So we'll try and give you a little earlier than that, but please bear with us because we still have two outstanding speakers yet to present. So pleasure to now request Dr. Sachin Kedar, a very good friend and a professor of ophthalmology and neurology, the Cyrus H. Stoner Professor of Ophthalmology and Vice Chair of Education at Emory University, Georgia, and an outstanding speaker. So great pleasure having you here, Sachin, and thank you for helping organize this international conclave. And he'll be talking on ischemic optic neuropathy. Yes, Sachin, you're on. Yeah.
Okay, can everybody hear me now?
Yes.
Perfect. Thank you, Rohit, for that kind introduction. It's a pleasure to be speaking here today at the International Conclave. I have no financial interests to disclose. So I'll start with a brief case, which you will all quickly recognize. It's a 55-year-old male who wakes up with blurred vision in one eye that slowly progresses over 5 days. He's obese, he's got vascular risk factors. You examine him and he has reduced visual functions in the right eye. He's got a right RAPD, and you correctly localize it to the right optic nerve. You look at his nerve and it is swollen. He has a visual field defect in that eye. You look at the fellow eye, it is small, it is crowded, there's a very small cup, and you have correctly identified an anterior ischemic optic neuropathy, which is the commonest cause of optic neuropathy in adults above the age of 50 years. So you can anatomically differentiate them into the anterior variety where you see the disc swelling and the posterior variety where you do not see the disc swelling. Pathophysiologically, they can be caused by inflammation and are called arteritic type, or they can be the non-arteritic type, which is more common than the other variety. The optic nerve is divided into these 4 segments. The intraocular part is the one that causes the anterior ischemic optic neuropathy, primarily because of a tenuous blood supply to this region. So the orbital canalicular and the intracranial parts of the optic nerve are supplied by a rich PL network, which makes it really resistant to ischemia because the blood supplies are multi-source in origin. The intraocular part of the optic nerve, however, receives blood supply through these paroptic branches of the posterior ciliary artery from the circle of Zinhaler. And from the work of the great Sohan Here, we now think that the non-arteritic entry ischemic optic neuropathy is because of arteriolar circulatory insufficiency at the optic nerve head. Other mechanisms have been proposed, but really not have been proven. What are the risk factors? So when I talk to my patients, I talk about immutable risk factors, which means things that you can't do anything about. Age is a big one. Born with a small disc with a small cup, which puts you at a risk for a tight optic nerve causing ischemia of the optic nerve head. You can clearly see it on fundus pictures. We saw some of the pictures that Dr. Padmaja presented in the previous talk. Optic disc drusen puts you at an increased risk for this condition, primarily because there is tightness of the optic nerve head, and presumably that increases your risk for circulatory insufficiency over here. Cataract surgery, controversial, but a large series published, I think, a year ago showed that there might be a slightly increased incidence of this condition within 1 year of the surgery, particularly in those patients who have a disc at risk and who have other vascular risk factors. Systemic risk factors have been looked at in non-arteritic entry ischemic optic neuropathy, and major series showed that these patients do have hypertension and diabetes. Dr. Here also proposed that if the patient is susceptible to nocturnal hypotension, which means the blood pressure drops in the early morning, then they often wake up with visual problems in that particular eye. Sleep study, there is no questions at this time, increases your risk for having this condition, particularly in those with a disc at risk. It's a 4 to 6-fold increased risk. So I have now gone from asking people to consider getting it to encouraging them to go ahead and get it. It's an easily treatable condition and no reason to ignore it. Younger patients, younger than the age of 50 years, also have ischemic optic neuropathy, especially those with multiple risk factors, and you have to look out for those. What about medications? There are some that we know, and there are some that are not proven completely. The erectile dysfunction drugs are probably the most prevalent medications that are not commonly evident to us. Studies have shown that there might be increased risk in people who use the erectile dysfunction drugs, particularly if the patient says they used it just before the onset of ischemic optic neuropathy. And several database cohort studies suggest that there is an increased risk of almost 2-folds in people on these medications. We are all aware of the effects of immunodrone and interferon alpha producing this condition. And anecdotally, in my clinical practice, I have seen other medications such as linezolid also cause ischemic optic neuropathy. Natural history of this condition is important to know. 2 large series, the HERE series and the IONDT series, studied this. And we know that at about 6 months, vision improvement occurs in about 40% of the patients, or 40% of the eyes. Vision remains stable in another 40%, and vision deteriorates in about 20%. And so whenever a study is designed to test the efficacy of any medication, it has to beat these odds, and that's a difficult thing to do. Risk of involvement of the same eye or the fellow eye is considerable in this condition. Same eye is about 3 to 6% if you look at HERE series, about 15 to 25% in the HERE series, and about 15 to 20% in the IONDT. And having diabetes increases your risk. What about the risk for future vascular events? The results are conflicting. There are studies by HERE and Lee which showed that you may have an increased risk for cerebrovascular or cardiovascular events, but then there are other studies which say maybe not so. So the jury is still out for future vascular events. We don't have any proven treatment for this condition. We are all aware of Dr. Here's study using prednisone, but this was not a true randomized clinical trial. And so we currently do not recommend oral prednisone, at least in our practice at Emory. However, we do consider it on a case-by-case basis, especially if the patient's second eye is involved, or if they ask specifically for being prescribed a prednisone. The reason we don't do it is because you may cause inadvertent side effects from worsening their diabetes or high blood pressure. None of the other therapies have proven. The large clinical trial with intravitreal siRNA stopped prematurely because it could not reach its therapeutic endpoint. So at this time, management of ischemic optic neuropathy of the non-arteritic variety is primarily focused on reduction of risk factors, vascular risk factors, medication review, avoiding nocturnal antihypertensive medication usage to prevent nocturnal hypotension, avoiding anemia, hypotension, and sleep study. Although I say when indicated, I almost always get it in every patient with NAION just because of the risk of fellow eye involvement. So I'll quickly switch over to the next case, and the panelists and the moderators, you can stop me when it is time for me to stop. Hopefully I'll do it on time. A 79-year-old woman presents with transient monocular vision loss that occurred for 2 weeks, resulting in a complete loss of vision for about 2 days. She has headache. She complains of a swollen and a sore nerve on her temple. We palpate her temporal arteries, and it is really tender. And she has reduced vision in the right eye, but also in the left eye. She's got a large RAPD on the right side. So when you look at the fundus, you see, again, swollen optic nerves. It's a pale swollen optic nerve on the right side, slightly swollen on the left side with some cotton wool spots. So this, as you would have identified, is a case of arteritic AION, with the most common cause being giant cell arteritis, and the AION being the most common cause of vision loss in this condition, the others being ophthalmic artery occlusion, ciliaretinal artery occlusion. We often get blood tests to confirm this condition. And I often tell my residents, do not even wait for the blood test. As soon as you see a patient with giant cell arteritis in your clinic, go ahead and treat them with steroids and then send them for blood tests. Elevated ESR and C-reactive protein has been shown to have a very high specificity for giant cell arteritis and AION, with about 97% specificity. However, remember that 22% of patients with clinical giant cell arteritis may have a normal ESR C-reactive protein. We also know that these patients may have reactive thrombocytosis, mostly due to the inflammation, can be seen in 50% of these patients, and several studies suggest that this may portend an increased risk for permanent vision loss. Temporal artery biopsy is the gold standard and should be performed in all patients who are suspected of giant cell arteritis. And what I tell my trainees is, if you write the word giant cell arteritis in your differential, you have essentially obligated yourself to get a temporal artery biopsy. We all know that initially you can have a unilateral temporal artery biopsy, get a long segment, and have a dedicated and an experienced pathologist look at it, because there might be skip lesions that might be missed. Treatment should be, the biopsy should be done within 2 weeks of starting glucocorticoid therapy. Giant cell arteritis is a medical emergency. If you see one in your clinic, make sure you send them to a rheumatologist. There's fellow eye complications. There are vascular complications involving the aorta, the mesenteric blood supply, myocardial blood supply, and cerebrovascular disease. And if you look at this survival function in the graph over here, the cumulative 5-year survival is about 35%. So be very aggressive in the treatment of this condition. Don't do it by yourself. Make sure you have help from a rheumatologist or a primary care. Steroids remain the mainstay of treatment. We start with the induction of 3 days of IV steroids, followed by a long and slow steroid taper. I often use aspirin in these patients as an adjunct therapy. Recently, you would have all heard about tocilizumab, which has been proposed as a therapy for this condition. Remember, the studies that have been done using tocilizumab all were done on giant cell arteritis who did not have ischemic optic neuropathy. So we at this time do not know the role in patients with GCA who have ischemic optic neuropathy, and we partner with our rheumatologist and often end up putting patients on tocilizumab primarily for its steroid-sparing agent. Methotrexate has been tried in the past with mixed results, and recently abatacept was also shown to reduce the risk of relapse in these conditions. And our rheumatologist, I know of at least one patient who was on abatacept for this. Back to our patient, high ESR, high C-reactive protein, confirming that this could be giant cell arteritis. Patient was treated with IV methylprednisone gram a day for 3 days, discharged on oral prednisone 70 milligrams a day and aspirin. Results of the biopsy, classical for giant cell arteritis, with the dense inflammatory infiltrate and giant cells in the blood vessels and vascular occlusion. A month later, there was slight improvement of visual function, 660 in the right eye, 612 in the left eye. And so to conclude, non-arteritic anterior ischemic optic neuropathy is the commonest form of optic neuropathy in the adults above the age of 50 years. We do not have any proven therapy at this point. The arteritic variety of AION is a medical emergency, must be treated immediately with steroids. In fact, in my clinic, if I have a patient who has giant cell arteritis, they don't leave my clinic without me watching 70 milligrams of prednisone going down their throat. If you have them go to the ER, they will wait in the ER and they'll have their fellow eye involved. Partner with a rheumatologist to manage patients with arteritic anterior-ischemic optic neuropathy. Thank you.
Thank you, Sachin, for an excellent talk. I'll just go on to Dr. Sangeeta. Or Sangeeta Khanna, again, a very frequent expert for our neuro-ophthalmology sessions at the Aios. She's a clinical professor of ophthalmology and visual sciences at the Kellogg's Eye Center, Michigan University. She would be talking to us about optic neuritis, adult versus pediatric. Welcome, Dr. Sangeeta.
Thank you. Thank you for having me here. And some of you have met recently, so thank you again. This is a pleasure. So I just want to I'll put on the timer so that I don't go over, but I'm keeping it short and brief. The main, sorry, 1 second, it's not advancing. Okay. So what I want to talk about is our approach to adult optic neuritis and kind of highlight a few differences between adult and pediatric optic neuritis. So let's begin with what is typical optic neuritis, because that's what we want to do with adult optic neuritis. Is this typical or atypical? So a typical would be a woman in the age range of 20 to 50. But males can also have it, but less common. And it's an acute and subacute or subacute onset of vision loss, and it's unilateral. And the vision can fall over 7 to 10 days before stability, and it's often painful, and there's be pain on eye movements, and they will have decreased visual function and APD and a mild disc edema. That's the classic typical optic neuritis. And when we think of typical optic neuritis, we are thinking either an isolated optic neuritis, which is post-infectious or post-vaccination, or associated with MS. Either they don't completely have a full diagnosis of MS at that time, but may have a white matter or demyelination. So that could be a clinically isolated syndrome. Or dissemination in space and time, meeting the McDonald criteria for multiple sclerosis. But atypical optic neuritis is different because it's associated with specific autoimmune mediated pathology, and it's important to know about these and diagnose them at the time because the intervention is different. There is also other conditions such as sarcoidosis and autoimmune conditions which can cause atypical optic neuritis, but less commonly. And then it's good to know about a chronic relapsing inflammatory optic neuropathy is a type of optic neuritis which is steroid dependent but has no markers. So aquaporin 4 IgG, that is the NMO antibody. So that is just to review, it is a cell surface antigen on astrocyte foot-like processes. So here, these are the astrocytes, foot processes, and antibodies form to this in neuromyelitis optica. And the clinical features of aquaporin 4 optic neuritis, which one of the atypical optic neuritis is that one, eye pain is not very frequent. It's often bilateral. So if it's a bilateral optic neuritis, you want to definitely work up for this. Vision is much worsely affected and the outcome is poor, and recurrences are frequent. So they need to have preventative therapy. And other symptoms, they may have area postrema involvement, so vomiting and hiccups, myelitis, which is often longitudinally extensive in these patients. And that is important to keep as a diagnostic criteria. And when you do an MRI, it can give you, MRI orbit can tell you if it is more features of atypical optic neuritis, such as in aquaporin 4, you'll see long segment involvement and like a large portion of the optic nerve. In addition, there is more of a chiasmal involvement in these patients. So this is the pre-chiasmal segment in a patient with aquaporin 4 positive disease. A MOG antibody is myelin oligodendrocyte glycoprotein. It's again a cell surface antigen, and this is present on the here on the oligodendrocyte. and antibodies form to this, and so that causes MOG-associated disease. And with this, they often have eye pain. Again, bilateral disease is common. Disc edema is profound. Vision can be very severe, but outcome is much better than aquaporin 4 atypical optic neuritis. Recurrences are frequent, and on MRI orbit, again, you have a long segment disease with perineuritis. They can have a spillover in the orbital fat. Let's just look at two cases. A 24-year-old with no past medical history, subacute decline in vision of the right eye with pain on eye movements for 1 week. The vision is down in that right eye. There's an APD, there's a central scotoma. It's unilateral, she's young, she has pain on eye movements. You want to go ahead and consider the differential diagnosis of optic neuritis, possibly typical. So let's get an MRI. An MRI orbit will shows you the enhancement of the optic nerve. This is the coronal and the axial. Remember here that not if you suspect clinically optic neuritis, not all patients may show enhancement. Some may show just signal change. So keep that in mind when you diagnose optic neuritis. And you'd get an MRI brain. It shows white matter hyperintensities on FLAIR imaging as seen here. So this is a patient who fits in the at least a clinically isolated syndrome, has demyelinating lesions in the brain, and has optic neuritis. And is in the typical it's a typical presentation. So looking at a case 2, this is a 56-year-old outside your normal range for typical with painful, but it was a painful decrease in vision just in the one eye, 2200. This is the appearance of the optic nerves, very mild edema. When you do the MRI, though the clinical features, there was one atypical feature of age, but the rest was unilateral painful. When you do the MRI orbit, it shows you it's a long length with the spillover in the fat. So that's an atypical, that's a second atypical feature. And this patient, the case 1 was typical, case 2 is atypical, as you see, 2 atypical features. And she had MOG antibody positive. This is the MOG cell-based assay, and positive as 1 in 1,000. So why is it important to distinguish the two? Because their treatment is different and the prognosis is different. And the treatment plan for typical, we get it from this very well done study, the optic neuritis treatment trial, published first in 1992. And it involved 487 patients with typical optic neuritis, and had their 3 arms, one with oral prednisone at 1 milligram per kilogram per day for 14 days, a placebo arm, and an IV salmeterol or methylprednisone 1 gram daily for 3 days. So what they found was that with the oral prednisone at this dose, there was increased recurrence. So we don't want to use that. But there was no difference in the placebo and the IV methylprednisone arms in terms of visual recovery at the final endpoint. So when you have atypical optic neuritis, however, there are differences. You have to give them IV methylprednisone. There is no role of observation in those cases. And they may also need additional plasma exchange if their vision does not improve. And that decision can be made based on how their vision is improving, or what is the concern for neuromyelitis optica, because if it's aquaporin 4 disease, you want to do early initiation of plasma exchange. IVIG can also be used for assisting in patients who do not respond to steroids. In addition to this, we need long-term relapse prevention in both patients who have aquaporin 4 disease and in some patients who have MAG positive disease. So in our case 1, which was typical optic neuritis, she actually chose to get treated with prednisone. IV methylprednisone would be what you would give her. We did give her an equivalent oral dose of prednisone at 1250 milligram. We do remember, even though we gave we used oral prednisone, we did not give 70 milligrams, which is contraindicated. We could have offered her observation, and that would be absolutely fine. Case 2 is atypical, so she got IV methylprednisone for 3 days. She actually recovered well, had a slow, longer taper of oral prednisone, and then she relapsed. So she was started on rituximab. So in addition to treatment information, this trial also gives us prognosis for multiple sclerosis. What they found in this graph that you can see that if the patient has more than one lesion on the MRI, a white matter lesion, they have higher risk of developing multiple sclerosis, and that risk at 15 years is 72% versus 25% if they have a normal MRI. So that's something with typical optic neuritis, you prognosticate for multiple sclerosis. So I'm just going to end with this slide. This slide summarizes the differences between pediatric and adult optic neuritis. And the main things to pay attention to is in children, they often present without pain and they have more disc edema. And the disease can be bilateral or unilateral. So keep that in mind, that they may not complain of pain. And we don't have the ONTT for children because they enrolled 18 plus, but the treatment is drawn from ONTT. Also, there is more use of IVIG in children, especially if they are MAG positive. And note that the children, the same criteria have applied in the case observation series, that higher age and more than one lesion, a demyelinating white matter lesion, does increase the odds of MS just as in adults. However, the overall risk of multiple sclerosis in pediatric optic neuritis is lower than adult. More children have MAG positive disease, so always check for MAG and neuromyelitis optica antigen, the aquaporin 4 antigen as well, the antibodies to that antigen. I'll end here. Any questions?
Thank you, Dr. Sangeeta. Thank you very much. We have Cornea Society International waiting in the wings. So we'll just have one or two quick talks, quick questions, if there are any, to bounce before we quickly hand over. Unfortunately, we also got the hall a little late. So although we finished with our talks, if there are any questions or remarks, Sachin. And again, thank you, Dr. Namrata, who's now joined us, for giving us the opportunity. And Sachin for holding such a wonderfully interesting and most informative neuro-ophthalmology session. Yes, Sachin, any comments on anything and a few pearls for everybody to take home with?
I just wanted to say that, we covered a broad swathe of optic nerve diseases and the visual field defects that one might see from the afferent diseases. So it was a wonderful session, and I hope everybody gained something from it.
Dr.
I just have one question to Dr. Sachin. Do you still advise your hypertensive patients to skip or ask your physician to avoid the night dose of antihypertensives? Because many physicians are very skeptical in changing that night dose. Because according to their studies, they have been proven that the night dose avoids many of the cardiovascular risk events.
I have not run into that problem in the US because nowadays the antihypertensive medications are pretty long acting, and our primary care and cardiologists are happy to move them over to a morning dose. I have not run into that situation here.
I would say we've had this issue because many patients, hypertensive patients, particularly in India, tend to have an evening peak. So we would have, in our discussion with the physician, they find that, most patients peak at around 7 to 8 p.m. or so, 6 to 8 p.m. or so. Either it's a long day or it's coming home stress, but those are the possible reasons why, they have. So generally we request them to kind of give the evening or night dose a little earlier so that they can avoid that late night, midnight drop in the blood pressure. But yeah, even physicians here are not very comfortable with the idea because, as I said, most of them find the evening peaks to be a rather, important problem to handle.
Yeah, at the end of the day, if the risk of having a major event is there, then I don't insist on it. But most of the times they are okay.
And Dr. Sangeeta, how frequently you go on for the next line, rather how long you wait for the response for your treatment in adult optic neuritis, particularly when you choose Plex?
Yeah, I think that you want 2 weeks would be a general guideline. But if it's aquaporin 4 positive comes back within 5-7 days, then or they already have high suspicion, then you start sooner.
Even if they are seronegative for both the markers?
If they're seronegative, you can wait 2 weeks and see if they're responding because the efficacy of Plex also goes down later. So, but at the same time, you want to give them some chance with just steroids because of obvious risks of Plex.
You're more aggressive, even clinically suspect NMO. So
unless you have clinic, yes. Yeah, if it is fitting the neuromyelitis optica spectrum disorder and they don't respond, I guess if it's seronegative, some people would still wait for 2 weeks unless it's very severely affected and you want to intervene early. That's.
Yeah, I think even before the results come in, I move to Plex if they have a very severe vision loss at onset. I used to have a cutoff of 1 week, but Prem Subramaniam from the University of Colorado, where his colleagues do a lot of research on this, says he starts day 1. He says every day that you lose to NMO is a day of irrecoverable vision loss.
So thank you, Dr. Naveen. Any last words, President Aios, and then we'll hand it over.
Not at all. I'm just happy that we were able to partner with AIOS, and I hope the audience enjoyed this feast of optic nerve diseases and very, very clear talks, especially by Sachin, Sangeeta, and Matt, and Padmaja as well. Just wanted to thank you all for that.
Thank you. Thank you so much, Rohit. Thank you. And thank you, Dr. Naveen Jaikumar. Thank you so much. And the entire Aios. Thank you.
Thank you. Thank you, Matt. Thank you. All the best for the coming sessions.
Cornea Society.
Thank you.
I would request Dr. Yuri to please take over.
Of course, happy to, especially after this really interesting session on neuro-ophthalmology. Always something new to learn, especially coming from cornea. Good morning, everyone in the US, and good evening to everyone joining from India. My name is Ori Soiberman. I'm a cornea specialist at Wilmer Eye Institute, and I'm super happy and excited to be moderating this session together with Professor Namrata Sharma. This is the Cornea Society Symposium for the All India Ophthalmological Society. And the topic of our session is on cornea and lens-based astigmatism management. We have lined up very distinguished speakers here, both from the US and India, and we're looking forward to hearing what they can teach us about astigmatism. So without further ado, I'm going to introduce our first speaker, Dr. Shahzad Mian, who is the interim chair of ophthalmology at the Kellogg Eye Center of the University of Michigan. Professor Mian, I'm going to hand the mic over to you.
Hello, everyone. I hope you can see my slides okay. It's
Yes,
really a great
yes.
pleasure to be here with everyone and participating in this session on with Aios and the Cornea Society. So I'm going to be speaking about role of phakic IOLs in correcting astigmatism. I have no conflicts, financial conflicts of interest. I'll start talking about a case. This is a 35-year-old male who presented in our refractive surgery clinic to see what we could do to help him reduce dependency on glasses and contact lenses. He just has a history of wearing glasses and in the past has worn rigid gas-permeable lenses off and on, but was out of them for at least 2 months prior to presentation for his evaluation. No other really pertinent history except in his social history. He is an engineer, pays attention to details, interested in seeing well, and you can see his hobbies listed here as well. His refractive error was stable at a refraction, as you can see here. He's a high myope, minus 950, minus 1050, with a high degree of astigmatism in both his eyes, but is able to refract well, corrects to about 20/20 with that working distance with those glasses and with the manifest refraction. His cycloplegic refraction was similar as well. His other exam findings, he has relatively thin corneas, but otherwise relatively stable, maybe a little bit on the drier side. Here is his corneal imaging in his right eye. You can see that his central Ks, although are relatively within normal range, he clearly has a pattern of inferior steepening with a Kmax over 50, a bit of posterior elevation, although somewhat decentered superiorly, and again, confirming the relatively thin cornea. And the left eye has similar findings, if anything, slightly worse than the right eye was. So certainly when patients like this present, there are options to consider. We can certainly talk to patients about continuing to use their glasses and contact lenses, especially if they're functioning well with them. But if they're looking for glasses or contact lens independence, what can we consider here? Corneal laser ablation is not a good option in this case because of all the obvious factors: high correction, astigmatism, thin cornea, and irregular corneal topographic pattern, really consistent with keratoconus, although he refracts to 20/20. So therefore, lens-based surgical options are important to consider, including phakic intraocular lenses and refractive lens exchange. In this particular case, he is also 32, so being at the age he's at, preserving accommodation is a factor. So we chose to do a phakic intraocular lens approach with the EVO ICL. This basic surgical technique is relatively simple. 2 paracenteses, 1 to 1.2 millimeters. You want a good dilation, although we attempted to dilate him preoperatively. He did not have great dilation, but with intracameral lidocaine and epinephrine dilated fairly well. Using a viscoelastic, but not overfilling the anterior chamber is really critical because the viscoelastic will get trapped underneath the ICL. The incision is a little bit larger than our typical cataract surgery incision, closer to 3.0 to 3.3 millimeters to allow the lens to be injected. There are a couple of injection injectors that the STAR ICL comes with. You want to try to avoid as much air bubbles as you see here because they will obstruct your view, but the lens goes in fairly quickly, so you have to kind of control the modulation. You can put viscoelastic on top, and then it's tucked into the sulcus underneath the iris and positioned with the alignment marks to allow for the astigmatism correction. And for the most part, the amount of manipulation you have to do is relatively limited, up to maybe about 20 degrees to off-center from the 180-degree axis to allow for proper astigmatism correction. And then usually it takes a little bit of myocol to constrict the pupil on top and flush out the viscoelastic with bimanual IA. This patient did very well, even on the day of surgery, which is an important part of follow-up care for these patients to make sure the IOP is okay. Was 20/20 uncorrected, and even by 1 week had a very good uncorrected vision, was very happy with his outcome. In the United States, we've had a few options available for phakic IOLs. The anterior-chamber lens format is not available anymore, although it was for a number of years. The Visian platform for STAR was the main type of phakic IOL that was utilized until recently with the availability of the EVO platform. Both of these, the Visian and EVO, are posterior chamber phakic intraocular lenses to correct nearsightedness only. And really, especially for the Visian, maybe less so for the EVO, the higher corrections are really for reduction of myopia. Correcting up to -20 is challenging, predictably, but we can correct astigmatism up to 4 diopters. I'm going to primarily talk about the Visian or the STAR platform ICLs because and EVO, because this is what is the main phakic intraocular lens that we utilize in the US at least. This is a collagen copolymer material that has been utilized for really nearly 3 decades in different lens platforms. It's highly biocompatible, hydrophilic, and has strong tensile strength and resists tearing as you're putting it in. Does have a UV absorbing chromophore. It functions by placing in the sulcus with a vault over the natural lens. The haptics again are placed in the sulcus with a 500 micron optic over the crystalline lens centrally. There are 5 full thickness ports, which are 360 microns in diameter, which was felt to be a optimal size to allow aqueous permeation around the lens to minimize injury to the crystalline lens over time and minimize cataract formation. The selection criteria as defined by the FDA approval process are for high myopia between ages 21 and 45, and again, cylinder up to 4 diopters. The spherical equivalent range is -3 to -20. Of course, you want to make sure the patients have a stable refraction, and one critical measurement for phakic IOLs, of course, is anterior chamber depth to be equal or greater than 3 millimeters. It is important to consider endothelial cell density, and the requirement for endothelial cell density, or the recommendation at the very least, are based on patient age and anterior chamber depth. Younger patients should have higher endothelial cell count ratios, and of course, the deeper the anterior chamber, the requirements are a little bit lower, but this table can be utilized as a guide in making decisions about selection criteria. If based on FDA criteria, again, this is not approved for patients who are less than age 21. The typical other things that we consider are pregnancy or lactation. Based on the placement of the lens, of course, corneal pathology and endothelial cell counts become very important, as well as the anterior chamber angle and degree of glaucoma, if present, may be a big factor as well, all related to the anterior chamber depth. Preoperative evaluation certainly includes a full ophthalmic examination, which again should cover endothelial cell density, gonioscopic assessment of the angle, the axial length, and a horizontal white to white, which is typically what's used for sizing the lens for placement in the sulcus. And then STAR has its online platform for calculation for what lens to order based for the size and power of the lens. Because it's a hydrophilic lens, it's really essential to keep it moist throughout the process and really try to inject it once it's taken out of the balanced salt solution it's stored in, and placing the injector into the eye within a few minutes. So timing is important to minimize any injury to the lens because it's hydrophilic. Couple of different injectors available, the Leolis, the newer version that STAR has, which both are relatively simple to use and allow predictable injection of the lens into the eye. With respect to the OVD, it's important to use, the recommendation is for a low molecular weight hydroxypropyl methylcellulose or a dispersive agent with low viscosity so that it's easier to remove but coats the surface where you need it to. The vaulting of the lens is really a critical feature in terms of minimizing issues with respect to injury to the lens, as well as reducing risk of having IOP or cell count issues over time. The optimal vault is 250 to 900 microns, but essentially about 50 to 150% of the corneal thickness. I usually try to size it to the thickness of the cornea as long as it's in the normal range. Vaults that are too high may, or too low or too high may cause problems. In the bottom set of pictures, the one on the very left of your screen is a normal vault. Here, there's a minimal vault and it's too flat. And on the right, the vault is too big. And that, of course, that correlates to the anterior chamber depth as well. So what about the data in the US FDA studies for the EVO approval? This was a series of 200 eyes with a mean refractive error preoperatively of minus 4.6. They showed at the 6-month follow-up that 94% of patients were 20/20 or better. With respect to how many patients distance vision gained vision lines, really essentially all of them were no change or had gained additional lines of vision. A retrospective review of studies published on the EVO platform with over 4,000 eyes found similar results, that over 90% are within half a diopter of accuracy of correction, 99% nearly within 1 diopter of target, and complications with this platform relatively low in this series of patients, with no cataract formation reported, perhaps related to these full thickness holes. 1 patient with pupillary block still reported, and minimal other issues overall. How about the toric ICL platform? This was a series of patients looking at a refractive error of -9 sphere and -2.67 cylinder, showing follow-up to 12 months with very stable results and good correction of spherical error and overall good correction of cylinder as well, but not as good, not fully corrected. Patients do end up on average having about a -0.5 refractive error. What about complications? There is a whole host of complications to consider. Preoperatively, they're all really based on sizing and power of the lens to get the best results. In the Visian platform, we did need to make sure that we had adequate sized peripheral iridotomies, but that's not so much of an issue with the EVO platform. Intraoperatively, most of it is really related to the insertion and filling of placement of the lens in the sulcus to avoid trauma to the crystalline lens, and also to make sure that we avoid trauma to the corneal endothelium and minimize issues with intraocular pressure. Long-term complications, it's important to recognize that these patients can have significant glare and halos, and even with the, these are results that are focused more with the Visian and Verisize. We don't have great results still available with EVO platform, but in general, the rates are significant enough to it's important to share with patients, but tend not to be severe enough to be too functionally disabling, although patients do report night vision and night driving difficulties, especially with the Verisize and Visian platforms. Broader issue with cataract formation also seems to be lower again in published series with the EVO platform, as well as IOP elevation not reported again. Endothelial cell count loss can still occur with, of course, with any of these platforms based on surgical technique and sizing of the lens, but seems to be on the lower end with follow-up. So just in summary, it's important to consider use of phakic intraocular lenses because they can allow us to correct a much wider range of refractive error and can be utilized in relatively thin corneas, even if they have other issues such as dry eye disease. They're overall relatively safe and have long experience in use, especially with the ICL and posterior chamber placement. And theoretically, they are removable, although that's not something we necessarily advise our patients when making these decisions. Thank you.
Thank you, Dr. Mian. And, while I'm uploading my presentation, I do have a quick question for you. So there are some proponents for using UBM biomicroscopy or anterior segment OCT to get better estimation of the sizing of the sulcus. What are your thoughts about that?
Certainly, I think getting additional information is also always useful, but I don't routinely use UBM in this for this purpose. I don't find that it necessarily adds a whole lot of value. I have primarily used white to white, and the two measurements that I do are looking at the pentacam white to white, as well as just using caliper tool to confirm that it's similar. Although, again, that's more of an approximation. I find that both of those tools are useful. There are some studies which indicate that the white to white doesn't always correlate with the vault. So although it is important to consider because we have different sizes that are available, there may be other anatomic factors such as the crystalline lens size that may, and the posterior chamber size that may influence the vault of the ICL.
Thank you. Yeah, I believe that at Wilmer also, Scott Bauer does the same thing, goes for the white to white. Okay, so I'm gonna be giving a talk about, let me just time myself. I'm gonna talk about case-based approach to the management of post-keratoplasty astigmatism. And hopefully this presentation will run nicely. Okay, so these are my financial disclosures. So we know that astigmatism after keratoplasty is a big problem. About 20% or up to 20% of our post-PK patients will have more than 5 diopters of astigmatism, and the astigmatism leads to bad vision, to reduced contrast sensitivity because of the degree of the irregularity, because of the higher order aberrations, and also the forward and the back scatter of the light can cause glare and photophobia. Overall, this is a reason for why a beautiful clear graft would still not provide good vision. So there are many ways of managing this condition, starting first of all with the glasses and most importantly, contact lenses, which can really help with even the most severe cases of post-keratoplasty astigmatism. But there are more invasive procedures, starting with something minimal, such as suture management, but going all the way down to additional surgery, such as cataract surgery with toric lenses, wound revision, and finally repeat keratoplasty. So I'm going to be presenting some of my cases of patients who developed astigmatism after PKs or DULCs, and we'll see what I did with them. So this is a case of a 48-year-old patient with a contact lens related corneal ulcer that of course grew multiple organisms which all looked like contamination, but did have multiple repeat negative results from fungal and acanthamoeba cultures. This patient did not respond to fortified antibiotics, and at some point we decided to do PAC-CXL. So we cross-linked him, and immediately after cross-linking, the eye became very quiet, but did develop this central corneal scar right over the visual axis with a scleral lens, which this patient really did not like. Vision was 20/40, and this patient wanted us to go ahead and do surgery. And you can see in this attempted DULC how the scar goes to the deeper layers of the cornea. Unfortunately, here we're getting what looks like a type 2 bubble, and we had to convert to PK. After we finished removing the sutures, we found that this patient still had 15 diopters of with a rule astigmatism, obviously very bad vision. In this case, I referred him to one of our optometrists who definitely came to the rescue with a contact lens. Again, this patient did not like scleral lenses, so the optometrist here went for an intralimbal rigid gas permeable lens. And with that lens, vision was 20/30, so much improved than the uncorrected 2400 vision. This is another case, a patient with advanced keratoconus, and here we did groove and peel DULC. So we're doing the peripheral dissection here. And after that, after we finish the dissection, we're peeling off the stroma, leaving very little stroma behind. And this patient did pretty well. So 1 month post-op, vision is 20/70 uncorrected. There's about 3.6 diopters of astigmatism at 171. 3 months after the cornea is cleared, there was more astigmatism. There's about 6 diopters at 153. And about 1 year post-op, and after I did a selective suture removal, the astigmatism is significantly removed from 6 diopters to about 1.3 diopters at 170. And just with glasses, this patient sees really well. You can see that the refraction is really minimal, and the cylindrical part is 1.5 diopters only. This is a case that I got from Dr. Ravi Patel from Atlantic Eye. This is a patient that had bilateral PKs. In the left eye, this patient had 11 diopters of regular astigmatism, regular oblique astigmatism at 61 degrees. And in this case, Dr. Patel did astigmatic keratotomies. This is how the patient looks a few months after. There's a markedly reduced amount of topographic astigmatism, reduced to 3 diopters from 11 diopters. And you can see here on the slit lamp image that you can barely even see the scars from the AKs. This is another patient with advanced keratoconus and also a significant amount of cataract. In this case, because the Ks were so high, I decided to go for a staged approach, and I started off by doing DULC. So I'm doing here a very archaeological and lamellar DULC, where I'm going lamella by lamella, and trying to remove as much of the cornea as I can. And you can tell that by the time I'm done, the cornea is pretty clear. So I think that we really did thin it out. And this is how it's looking after we put the corneal cap on top. And after all the sutures are removed, there's still some astigmatism in this cornea, about 2.6 diopters. It looks pretty regular. And as I said, this patient still has a visually significant cataract. And in this case, I offered the patient to have cataract surgery with a toric lens. You can see that using this calculator, had we used a toric lens on SA6AT6, that patient would have had a minimal amount of astigmatism, about 0.1 diopters with flipping of the axis. This is another case. This is a 70-year-old patient that had PKs done for keratoconus 40 years ago. Never had really any improvement in vision after the surgery. You can see here that the graft is decentered. There's a lot of scarring inferiorly, and I'll just try to put the laser pointer on. This area here is very, very thin. So all of this scarred area is extremely thin, almost all the way down to the limbus. This patient also has a very significant cataract. And this patient, as you can see here, there's a 19.3 diopters of astigmatism. The thickness of the graft over the pupil is about 600 microns. So I didn't think that the graft was failed. And when I started talking to the patient, it became very evident that this patient did not want something big. I offered her initially to have just cataract surgery and see how that goes, but look at the numbers. So the axial length is 30 millimeters, so about 4 millimeters away from her fellow eye. And the Ks are just all over the place. And there's about 27, 28 diopters of astigmatism over the cornea. Even the only lens that would bring this patient to emmetropia was a minus 24 lens. We just don't have these lenses. So I came up with this case report that was published in Cornea in 2022, cornea plication for ectatic PK graft. And in this technique, the authors describe how they took an ectatic graft and plicated it on top of the thin area. Vision improved from count fingers to 20/32. So a significant improvement in vision and reduction in astigmatism. So we try to do the same approach here. So here's the video. We're starting off with marking the area of the plication, that very thin area, removing the epithelium and using the diamond burr to roughen the stroma. Again, remarking the area and starting to pass off sutures to approximate those two areas. You can tell that the eye is soft. I'm pressing on it, but it's still very hard to bring these two areas together with the first suture. But as we go along and place more sutures, it's becoming much easier to really bring those two ridges together and to plicate that very thin area. Now, just for the sake of time, I'm going to continue. And this is how this patient looks at post-op day 1 after surgery. So the graft did not fail. You can see the plicated area on the interior segment OCT. And there's a marked reduction in astigmatism from 19 diopters to about 5 diopters, much more regular. Over time, there were changes in the astigmatism, and I started removing the sutures selectively. The plicated area still remains intact, and on the last visit, this patient has 2,400 uncorrected vision, so much better. Graft has not failed, and the astigmatism is reduced to about 7 diopters. So just to finalize, post-keratoplasty astigmatism is a common problem after PK, and the treatment definitely has to go, first of all, through hard lenses. And if that fails, there are many other surgical methods to address astigmatism. Thank you very much. This is my email if anyone has any questions. And with that in mind, I'm going to stop sharing. Okay.
Excellent talk, Udi. This is so nice to see all the videos and good way of management, very high astigmatism. And really, it is a learning point for all of us. So our next speaker will be Dr. Tony Aldave. I think he will be presenting from slides already loaded. That is femtosecond laser assisted AK for the management of post-keratoplasty.
Hello, my name is Tony Aldave. I'm the co-chief of the Cornea Service at the Stein Eye Institute, UCLA. I'm sorry that I was not able to participate in this International Ophthalmic Conclave live, but I'm currently en route to Vietnam, so I had to record my talk. The topic of my talk is femtosecond laser-assisted astigmatic keratotomy for post-keratoplasty astigmatism. By way of disclosure, I have no financial interests that are relevant to the subject matter of this presentation. So the first thing you may ask is, do we need to be concerned about treatment of post-keratoplasty astigmatism? After all, corneal transplants, full-thickness transplants, that is, are much less commonly performed than they used to be. And that is the case, but we can see data from the Eye Bank Association of America shows us that last year, or 2 years ago now, that there were just over 15,000 full-thickness transplants performed in the U.S. So we still have a lot of patients receiving full-thickness transplants domestically, and I'm sure in India as well. So the answer is yes, we do have to have ways to address high astigmatism in these patients following keratoplasty. So why would we use the femtosecond laser to manage post-keratoplasty astigmatism? Well, it has several advantages. One is it allows us to precisely control the depth, the length, and the location of the incisions, which equates to less surgically induced astigmatism. Also, because we use a suction ring, it obviates the need for globe fixation during the incision creation. You can see in this video here that's on the slide that the patient has significant nystagmus, but the nystagmus is dampened or actually canceled out with the use of the suction ring. There are some disadvantages, however. One is increased cost. We are not reimbursed for using the femtosecond laser for astigmatic keratotomy domestically. We get paid a certain amount for doing astigmatic keratotomy, and that's it. So there's a a bit of a financial disincentive. There's also a risk of wound dehiscence in a patient who's had a prior keratoplasty, a penetrating keratoplasty or DULC, or a bleb rupture during the procedure. This image is a patient of mine with a diffuse avascular superior bleb, in whom I performed femtosecond laser-assisted astigmatic keratotomy, and who developed a slow bleb leak after the procedure that fortunately spontaneously resolved. And one of the other disadvantages is we don't have a specific nomogram, at least we didn't previously, for performing femtosecond laser-assisted astigmatic keratotomy following keratoplasty. So let's talk about if you're going to be performing this procedure, the preoperative planning, the technique itself, some of the results, and then I'll discuss the nomogram development. So first of all, preoperative planning. When I began performing femtosecond laser-assisted AK many years ago, I used the HANA nomogram for correction of post-keratoplasty astigmatism. You can see in the table that as the refractive astigmatism increases, the diameter of the optical zone decreases, the incision depth is constant at 75% depth, and the length of the incision increases from 60 up to 80 degrees. Now, how is it performed when you're doing it with a femtosecond laser? Well, the laser that I use is the Intralase IFS. In this case, we are in the keratoplasty mode. We turn on only the anterior side cut, and we set the depth of the incisions. And I'm usually going, you'll see in the nomogram that I'll present to you later, somewhere between 80 and 90% depth. When you have these paired incisions, the depth has to be the same of the two. The diameter, and again, both the incisions are the same distance from the center of the treatment. The energy is the same for both, but the position can be different. These two incisions you see are not opposite one another, and they also don't have to be the same length. So you can vary the incision length and a position as well. The side cut angle is the angle at which the incisions are made, and I typically keep it at 90 degrees. Now, when you have a patient beneath a femtosecond laser prepared to perform these cuts, you can typically see the graft-host junction fairly well to be able to center the astigmatic keratotomy incisions. However, sometimes they can be hard to see, especially if you've done a femtosecond laser-assisted keratoplasty. In that case, if you do a zigzag cut, for example, there is no distinct graft-host junction. So it can be helpful to make a mark on the cornea, as I've done here, with an inked tree fine before putting on the suction applanation plate, so you can see where you want your incisions to be created. So here's a patient who's had a keratoplasty. You see 5 sutures remaining. After they were removed, the patient ended up with a fairly high astigmatism of 6.4 diopters, but you note that it's fairly regular and symmetric, so a good candidate for astigmatic keratotomy. So here's that patient's video. In this case, you'll note that I have used a tree fine that's inked to help me identify where the mark should be created. But again, the graft-host junction is a sufficient visual guide. You don't need them here. And you note these incisions are created in just seconds. Obviously, if you note bubbles in the anterior chamber when you first start to make an incision, implying that your full thickness, you would stop immediately, reset the depth for not as deep, and then continue the treatment. Following the treatment, I usually open up the incisions with a Sinskey hook because there often are tissue bridges that are present. You note in this patient, the astigmatism went down to about 3.6 diopters. So you're not eliminating it. All of us who do AK know that. You're really just debulking the astigmatism to get to a level that could then be corrected with spectacles. I have performed this also for patients who have high astigmatism following DSEC. So here's a patient here who had DSEC, had very high astigmatism afterwards, probably high pre-existing astigmatism, and then also may have been exacerbated by the placement of my corneal incision. So 9 diopters of astigmatism. Now you note though, after the treatment, you can see the incisions. Again, I used an inked tree fine to guide the incision placement. In this case, it was actually quite helpful because there is no graft-host junction to visualize. The astigmatism now is down to 1.9, so a very nice result. A word of caution, though, when you're performing femtosecond laser-assisted astigmatic keratotomy following DSEK, is when you're measuring the corneal thickness and you're determining the depth of the incisions, you do not want to incorporate the DSEK graft into those calculations. This is a case that was reported in JCRS of a patient who had a high astigmatism following DSEK. You note this is preoperative image here, had a high against the rule astigmatism. The incision depth was, I think, around 90% deep. But you note that the thickness of the cornea, including the DSEK graft, was used in the calculations. So the incision actually went full thickness through the the host cornea. And that resulted in a significant overcorrection, flipping the axes. The patient now had a high with the rule astigmatism. So I think if you're doing femto AK for a high astigmatism after DSEK, you should use OCT to determine how thick the patient's cornea is, subtract out the DSEK lenticule, and then decide the depth based on that. So what about the results? Well, years ago, I and David Rootman and Sonia Yu put together our cases of femtosecond laser-assisted astigmatic keratotomy following keratoplasty. We had 129 procedures. As you see, the vast majority of these were patients with prior PK or DALK. And here we're looking at the visual and refractive outcomes. If we look at the uncorrected distance visual acuity, here in the blue line, we note pre-op and logMAR 1.17, post-op 0.89. With the corrected distance visual acuity, decreased from 0.45 prior to the procedure down to 0.34, so nice visual improvement. The keratometric astigmatism on average was 8.3 diopters before the procedure and reduced to 4.6 afterward. And the refractive cylinder again showed a similar reduction. So overall, I think good results, but tell us again that we're reducing, not eliminating the astigmatism with this procedure. This is a double angle polar plot of the preoperative and postoperative keratometric astigmatism after femtosecond laser assisted AK. You can see here the pre-op and the post-op astigmatism. These red dots represent the mean vector astigmatism, and the red circles represent the vector centroid based on the standard deviation. So we can see a nice clustering of these points here following the procedure. So this led to the development of a nomogram for a femtosecond laser-assisted AK for managing post-keratoplasty astigmatism. The incision diameter in these procedures is between 6 and 7 millimeters. The arc length was between 60 and 90 degrees. We did not go shorter than 60 to avoid inducing complex quadrifoil astigmatism. In the incision depth, we varied between 75 to 90 percent, that should say. The maximum percent depth of the incision was set at 90 to avoid or really minimize the risk of having a full thickness incision. So here's the article that we published a number of years ago in JCRS. You'll note, similar to the Hanna nomogram, that as the astigmatism increases, we see that the depth of the arc length increases from 60 to 90 degrees. The incision depth, though, unlike the Hanna nomogram, does increase. The Hanna nomogram is 75%. This is 85 or 90. But I must say that I do tend to be a little conservative on this. I'm usually about 80, maybe max 85% thickness to avoid, obviously, a full thickness incision. And again, as the amount of desired correction increases, the optical zone diameter decreases. So in conclusion, femtosecond laser-assisted astigmatic keratotomy is effective at improving uncorrected distance visual acuity and corrected distance visual acuity and decreasing keratometric astigmatism and refractive cylinder following corneal transplantation. And the development of a specific nomogram has led to the optimization of refractive outcomes. I would really encourage you to consider using the femtosecond laser to manage astigmatism in your post-keratoplasty patients. I want to acknowledge the folks at the Stein Institute who helped with the nomogram development. Sonia Yu and Florence Cabot at Bascom Palmer, David Wong at KCI Institute, who was instrumental in helping us develop the nomogram, as well as David Rootman and Yakov Goldrich at University of Toronto. I thank you very much for your attention. If you're interested in getting a copy of this presentation, you can take a picture of the QR code that you see on the slide. Thank you very much.
Wonderful. This was a great talk from Dr. Aldave, and our next talk is going to be from Professor TTL.
Yeah, good morning and good afternoon to all of you. Let me share my presentation. Yeah, is my slides visible?
Yes, yes.
Yeah, thank you. Good afternoon, good evening, Dr. Basak. I think I would talk about toric IOLs in the management of astigmatism, in corneal astigmatism management. No relevant financial disclosure from my side. We all know that if you have astigmatism, which is more than one diopter in cornea, and if patient also has a cataract, then that's a very good option for treating with cataract surgery and intraocular lens implantation, that is toric intraocular lens implantation. We all know that IOLs, especially toric IOLs, will give the most predictable results in correcting the astigmatism, especially the corneal astigmatism post corneal procedures, or patient having a little bit of higher degree of cylinder. Because any other procedure, which may be suture adjustment or a arcuate keratotomies, may not be as predictable as intraocular lenses. Therefore, I think it is very important to consider in those patients where patient is not actually having the difficult ocular surface, we can consider toric IOLs for correction of corneal astigmatism. The proper patient selection, that is, I think, most important for us to give a good results in a post-op period, and that includes the biometry part as well as the good IOL power calculation for these patients. So just looking into the patient's expectation, I think the single most important investigation in such cases for making decision will be biometry, that is actually the keratometric power and the excellence for these patients. We all know that patients undergoing a refractive procedure, especially the refractive cataract surgery, one of the most significant problem which post-op patient faces is the residual astigmatism. The patient may not be very happy with the amount of cylinder they have to wear, or it will decrease the outcome of a patient who undergone surgery as such, because astigmatism per se will decrease the visual potential. So this is one patient who had cataract and had a high cylinder. You can see the biometry giving us more than 2.4 diopter cylinder, and which would be a regular cylinder, can be corrected by toric IOL per se. So any cylinder which is more than 1 diopter should think of a toric IOL if patient has some sort of cataract surgery. If you see, this is a difficult situation which we'll see in a post-keratoplasty patients, post-ectasia procedures, like patient undergone DALP, or a patient undergone some sort of cross-linking and has some cataract, then we can think of implanting toric IOLs. Corneal ectasia is one factor where we may not be able to correct the entire aberration induced by the cornea, but if we can implant the toric IOLs in these patients, also would decrease the power of requirement for subsequent glasses or a contact lens in these patients. And these patients would require the much thorough counseling that they may not see clearly with intraocular lens implantation, as such may require glasses or contact lenses subsequently to correct the corneal aberration, which is difficult to correct with toric IOLs. So this is one of a patient who had undergone keratoplasty and subsequently the intraocular lens implantations. And we did try to manage this with the suture adjustment by selective suture removal on the table. And if you have an intraoperative keratoscopy, you can still manage the suture adjustment in these cases. In fact, this is a patient where you implanted the IOL, which is spherical IOL, and trying to adjust. So this can be one way of looking these patients who develop cataract subsequently within the first few months of corneal transplant surgeries, where you can't remove all the sutures. But the requirement for a patient undergoing cataract surgery would be stable keratometry. For that, you may have to require to remove all the sutures. It may be within a first 1 year, after 1 year of surgery. Then wait for a 4 to 6 weeks after suture removal. Make sure cornea's parameters stable. Then you calculate the IOL power for these patients. So before we jump for surgery, it is very important to us to understand patient's need, and accordingly we should counsel the patient for surgery, especially if you are doing an intraocular surgery after corneal transplant surgery for these patients. The detailed ocular examination, especially looking for a tear film status, which is very important after corneal procedures, and look for a type of cataract, especially the grade of cataract, the anterior segment anatomy per se, the depth of anterior chamber, the peripheral anti-synechia, glaucoma part may be important for these patients. Most patients would be on a chronic topical medications. And if they have a glaucoma medication on, their surface will be definitely poor. So we have to stabilize the surface, then think of measuring the corneal parameters, which will give you a correct parameter for a IOL power calculation for these patients. The ocular surface management in these patients are very, very important. So we may require the topography done, especially the anterior curvature should be seen in these patients. In a difficult ectasia patient, sometimes you may require to do a pentacam, which will give you a nice EKR reading, which can be taken for a calculation of IOL power for these patients. The biometry should be done at least in the two instrumentations, especially for a keratometric values. If the keratometric values axis-wise, they are matching in the two instrumentations, then that case can be a good candidate for a toric IOL correction per se. And as far as axial lens is concerned, that is optical biometry will give you a better consideration. Some cases you may have to consider posterior corneal astigmatism also. That may also be taken into consideration for an ultimate correction of these patients. IOL power has to be as per the toricity of the cornea and axis, and always look for a surgically induced astigmatism, especially in a post-keratoplasty patients. You may have a significant change in the corneal parameters if you have a larger surgical incision in these patients. We should do a small incision surgeries. If possible, a femtosecond laser cataract surgery may be better for these patients. So to summarize the initial part, I think we require a cornea to be stable to have a regular astigmatism coming up. Multifocal IOLs may not be suitable post-keratoplasty patient, but if patient has a regular astigmatism after the suture removal, then we might consider putting multifocal IOL also in case the posterior segment is normal in these patients. And as I said, you need to have at least two readings for two different instrumentation for keratometric power. If needed, we should use a topography or a tomography to get a good reading for these patients. Always use formulas which can give you assessment for inclusion of posterior corneal astigmatism, surgically induced astigmatism, AC depth, and actually the affected lens position, and that might give you a good correction. Surgery-wise, we all understand the proper axis measurement and the position and implantation lens in these cases. Manual or image-guided system will be better. This is one of the video post astigmatic surgery where cornea had a 6 diopter cylinder with the astigmatism induced by the pterygium, which I had removed 6 weeks before. And after, I think this is after 3 months of pterygium surgery, the patient again required a toric lens implantation of T4. And if you have image-guided surgery, that helps you in giving a good capsular access. And the effective management can be done of a nucleus if you have an intact rexus in these patients. And it is very, very important to do a surgery to safeguard your cornea and as well as the posterior capsule. Polishing of the both anterior and posterior capsule is important. Complete removal of viscoelastic from anterior and the posterior part of chamber is also important just underneath the IOL, because retained viscoelastic may be the cause for post-op rotation of IOL. You can see this is axis 121 axis for implantation, which will effectively manage in these cases. But in difficult cases, if you have access to OptiWave analysis, ORA, that can also be a good guide for getting a good IOL power for difficult corneal parameter cases, especially post-radial keratotomy, post-LASIK surgeries, and post-keratoplasty. Sometimes aura gives you a very nice interpretation of IOL power like this. And after implantation, you can actually make sure on the table that your lens is well positioned and the requirement of a rotation is not there, and it gives you a right correction after you implant the IOL also. So this patient is nicely done after the aura assessment. The aura may be a good assisting system for a difficult keratometry case. So this is one of patient who had undergone keratoplasty earlier and done a toric implantation, did very well. Image-guided system will always be better in terms of giving better visual quality than manual marking in these cases. This is our results of cases where image-guided surgery did a better post-op outcome in these patients. The marking alignment may be sometimes difficult. Therefore, I understand physical marking may be avoided in a post-keratoplasty, post-ectasia patient. If you have image-guided, you might get a better result. So this is one patient who had undergone radial keratotomies. The corneal astigmatism was significantly higher, but we could get a very nice anterior and posterior corneal curvature with IOL Master 700. Therefore, we are doing a toric implantation in this patient. Some patient, as I said, if they have a large ectasia, they still may require a contact lens after implantation IOL. So that part has to be explained to the patient. This is completion surgery. I'm going to implant toric IOL in this patient, and patient did very well post-op in this case. Sometimes the IOL might rotate in these cases, especially a ectasia patient where AC duct is very big. You may have a retained viscoelastic, and if vision is less than 6/9 or as per the outcome, patient is not satisfactory, and the axis is more than 10 degrees, you may require a re-rotation. These are various ways to assess the requirement of toric realignment. You need to dilate the pupil, see the new axis of implantation of IOL, and the previous axis has to be taken into consideration, and you can rotate the lens according to a desired outcome for these patients. So this patient required a rotation of 74 degrees, had a more than 3 diopter cylinder post-surgery, post-ectasia patient where I did IOL, and after surgery, re-rotation, patient did a very well, and it was right onto the required axis and no rotation required. To summarize the toric alignment part, I think, as I said, you need to do a good assessment after dilatation, see the new axis of a lens and the past axis and refractive error, residual refractive error has to be taken into consideration. Always do a rotation within a first week if you think it's because of malalignment, because of some sort of a misdirected axis. If you think it's because of bag-related problems, IOL sizing, in those cases, you may require to wait for 3 to 4 weeks, then rotate the lens in these cases. I think that covers my talk on IOL toric IOL correcting the corneal astigmatism. Thank you for kind listening.
Thank you very much, Professor Tikial. Our next speaker is Ellen Koo. Dr. Koo is Associate Professor at Bascom Palmer Institute. Dr. Koo, take it away.
Yes, I will share my screen. Can you see my slides?
We can see it now.
Okay, perfect. Thank you, Dr. Soiberman, and thank you very much to Professors Basak and Professor Titial for having me today. It's terrific listening to all these talks because they are a really good segue to my next topic, which is putting it all together. It's my talk is entitled "Going Down the Refractive Rabbit Hole." I have no financial disclosures. The phrase of going down the rabbit hole was first used by Lewis Carroll in 1865. His classic Alice in Wonderland. And according to the Merriam-Webster dictionary, going down the rabbit hole means the pursuit of something such as an answer or solution, which then leads to another question or problem or other pursuits. And so the first case describes a 67-year-old patient who underwent myopic LASIK in 1998. 11 months before he presented to me, he underwent PRK enhancement of the left eye. In that eye, he presents with corneal edema. He states his left eye is blurry, and he follows up by saying, "It's important to me that I'm 20/20 after all this. I don't ever want to wear glasses. His uncorrected visual acuity in that eye is 2150, and his central corneal thickness is 606, so thickened. His best corrected visual acuity was 2050 with high cylinder and really fluctuation and MRX whenever he came in. So what was going on? So we looked at the slit lamp exam and it showed superficial patchy corneal edema and a visually significant cataract. And anterior segment OCT really put it all together. So I diagnosed him with interface fluid syndrome, which was consistent with the history of steroid usage after his PRK enhancement. His corneal edema was persistent despite cessation of steroids and good intraocular pressure management. So we presented our case series of patients with interface fluid syndrome at the recent World Cornea Congress meeting. We demonstrated that DMAC really affords great resolution of this phenomenon. So back to our patient had IFS with significant corneal edema, as well as a cataract that was visually significant. Again, he emphatically tells me, I don't ever want to wear glasses at the end of all this. So what to do? So here were the sequence of events. I performed this DMAC, then waited to stabilize his biometry. So I waited about 4 months, then proceeded with cataract surgery, and he ended up 2020 without correction. So he was happy. The second case is a 67-year-old woman with a progressing cataract. The nucleus sclerotic component had become significant. In addition, she had a significant posterior polar cataract. The posterior polar cataract is known to have abnormal adhesion to the posterior capsule. This is her preoperative exam. As you can see, the left eye cataract was visually significant. She was a moderate myope with a fair amount of astigmatism. So we discussed lens choices. Oh, again, she's adamant that she hates wearing glasses and wanted to see really well, distance and for near. So we discussed the option of multifocal toric IOL. So before I start the video, of course, when I meet her in pre-op bay, she reminds me again, she never wants to wear glasses for anything. So this is the video of the cataract surgery. So you can see it's a pretty dense nucleus. She really waited till this was really bothering her. And as you can see, there was some hydrodelineation without hydrodissection. The nucleus is carefully taken out. And when I do the IA, as the saying goes, save the best for last. So I really was trying to eat up all the cortex and avoiding that very last area of polar cataract, but it had to be done. We had to bite the bullet. So as I removed that last bit of cortex, I could see was continuous was the posterior capsule, filled viscoelastic. Hey, my bag is still intact. So you know what? I'm going to go for it. I'm going to put in my lens that I chosen, put in my suture, and gently, by making another paracentesis, I'm switching to bimanual to take out the little bit of cortex that's left. And all the while, you know, the main thing is to maintain a deep chamber so you do not have vitreous prolapse. And at the end, I'm just taking out the remaining viscoelastic. And, you know, I want to emphasize the biggest thing is to, when you take out your bimanual, to make sure you hit the AC with infusion as you withdraw your infusion handpiece. So this maintains a chamber without vitreous prolapse. And so everything went really nicely. She was happy with her outcome. This third case, this is a 65-year-old woman who travels several hours to come see me for a second opinion to improve the vision of her right eye. She had previously undergone a PK and she felt the vision had been gradually worsening. What was going on? So the best corrected visual acuity with spectacle correction was 20/60 in that eye. The slit lamp exam revealed a raised corneal lesion right at the graft-toes junction. Temporally, you could see the elevation, that hazy white stuff. So I diagnosed her with ACHD, acquired corneal subepithelial hypertrophy. So this corresponded to marked steepening on topography. So I performed a superficial keratectomy. Now, these things do really peel off very beautifully. And so after I got rid of the lesion, she had marked improvement of her clinical exam, as well as her vision at 1 month. Her vision was 20/30 with spectacle correction. And the topography shows improvement as well with better overall symmetry. So I thought that was a win. I thought we were done, but she goes, can you do more? So looking at the topography, although I've improved the overall asymmetrical astigmatism, she still had nearly 8 diopters of symmetrical astigmatism. So I turned to one of my favorite tools of the trade, the compression suture. After placement of compression sutures, you can see that she had marked improvement of cylinder and manifest, -8, cylinder of 2 at excess of 10. So again, I thought we were done. And really, you can see the marked improvement of the topography. The left is before and the right is after the compression suture. But she asked me, can you do more? I hate wearing a contact lens in just one eye. You have to keep in mind her other eye was almost emmetropic, so she had to wear a contact lens to avoid anisometropia. So we proceeded with PRK with mitomycin. And this is her topography 6 weeks after PRK. As you can see in the image, the astigmatism is now less than 2 diopters. And her manifest refraction shows a wonderful result. So the conclusion is, journey down the rabbit hole can be fulfilling and satisfying to the patient and surgeon. As corneal and cataract surgeons, we're in a really unique position to design a customized plan for the patient with tools in our toolbox, using a combination of corneal surgery, refractive surgery, and cataract / lens-based surgery. And yes, we absolutely can. Thank you so much.
Thank you, Dr. Koo. Those Florida patients are very demanding, so we see but beautiful outcomes. Okay, our next speaker, Dr. Vishal Janji, who needs no introduction. Dr. Janji is a professor of ophthalmology at University of Pittsburgh. Dr. Janji, please.
Can you guys see my screen?
We sure can. It's just not in presenter mode.
Yep, I'll get there. All right. Okay, well, thanks so much, everybody. Fantastic talk so far. You always learn so much. I mean, I was really impressed by the Neuro Symposium as well. I'm a little bit ashamed to say that, though. Okay, so my name is Vishal Janji. At the outset, I want to thank Aios, all my teachers. You know, some of them are on this call: Professor Titial, Dr. Namrata Sharma, Dr. Basak. I've learned so much from them over the years, and I'm really indebted to them. My talk is going to be on post-refractive surgery ectasia. We'll discuss a bit about diagnosis as well as management. I don't have any financial disclosures relevant to this talk. Briefly, if you look at the literature, the incidence of post-refractive surgery ectasia is only 0.04 to 0.6%, mostly post-LASIK. So we really don't know whether that is rare, which would be great, or is it really underreported. About half of these patients, they present within 1 year after the surgery. Of course, it's a devastating complication. You heard from Dr. Koo, demanding patients, start with 2020, end with 2010, nothing less than that. LASIK is still the most common reason for post-refractive surgery ectasia. PRK is supposedly the least common. SMILE, there are some reports, but we'll have to wait and watch. The histopathological findings are not very surprisingly similar to keratoconus. There are breaks in Bowman's layer. There's slippage in the interlamellar and interfibrillar regions. There are large interlamellar clefts as well. So a lot has been done in the past. Risk factors, the biggest risk factor is abnormal corneal topography. And we are really fortunate. When I was a student back in Delhi, we just used to have OBSCAN and VKG. Actually, not OBSCAN, we had a VKG. Imagine just relying on that instrument and going ahead and creating a flap. We used to do one eye at a time. Young age, residual stromal bed thickness, pre-op corneal thickness, high myopia, any enhancements. And I highlighted that enhancements because I really, in this day and age in the United States, most of my patients, fortunately, I don't have many for post-LASIK ectasia or post-refractive surgery ectasia, they have a history of enhancement done at some point in one of the eyes. There was a parameter that was sort of described a few years ago by Rendelman, PTA, which takes into account the flap thickness and also the ablation done. I really don't use PTA now, although it can be a really useful parameter. I think I still rely on a bunch of corneal topographies, especially if one of them is even borderline abnormal. Okay. Like we did that. Chronic eye rubbing, families of keratoconus and unstable refraction are other things that I do not ignore in these patients. Clinical presentation of post-refractive surgery ectasia, it's usually progressive increase in myopia. It happens years later. I'll show you some cases. There's irregular astigmatism, definitely loss of corrected distance visual acuity, and most commonly progressive asymmetric inferior corneal stiffening. That's what I see in most of my patients, along with corneal abrasions, which we try and use more and more nowadays in these patients. I just want to highlight, I saw this patient last month who had 2015 vision on the right eye and pinholing to 2015 on the left eye. He was referred for contact lenses because left eye had a +4 cylinder. And he, of course, he had history of LASIK about 20 years ago, and he was diagnosed with post-LASIK ectasia. So it can be this mild and this subtle compared to this patient who had LASIK more than 20 years ago, 23 years ago, I believe. And her first presentation of post-LASIK ectasia was with corneal eye drops. She was treated conservatively. As you can see, she did very well. And afterwards, actually, the eye drops treated her ectasia to a large extent by causing scarring in that quadrant. She did very well with contact lens fitting. This is another patient who happens to be a physician, and we worked together, who had LASIK surgery in 1990s. In 2008, he was told that he has some signs of ectasia. The K2s were 43 or so, astigmatism of 2 diopters. Somebody just sat on it for some time, and as you can see, 2 years later, he started to have some cylindrical error in his refraction. Visual acuity went down. Cross-linking had not yet arrived in the US, and he was not ready to travel to anywhere else. 2012, it became worse. Astigmatism shot up to 3.5 diopters. This is when I saw him. 2016, I advised that he should have cross-linking, which was just approved in the US at that point. And again, he wanted to wait for some more time. And this is 2019 when he finally had treatment done. So just looking at how post-LASIK ectasia, it can really progress. It doesn't matter what the age of the patient is. And you can see the patient was born in 1955. This is another patient who's 68-year-old, had LASIK done in 1999, progressive worsening of vision. She was bilaterally pseudophakic, YAG capsulotomy was done, was treated for dry eyes, and was being sent to oculoplastics for lid tightening procedure. We did the pentacam, and it's not a surprise there, astigmatism of 13 diopters. So pinholing to 2200, patient did not want any surgery done. Did a contact lens trial and visual acuity improved to 20/30. Patient was very happy, and she was 68. We just left her alone. 10 months later, she came back. The astigmatism increased to 15 diopters. So again, highlighting that you really can't get away by doing nothing in post-LASIK ectasia. You really have to do something. This is what we follow. It's pretty straightforward. Contact lenses, they're a part and parcel of what we do for ectasia patients, for astigmatism, whether that's before cross-linking, after cross-linking, before transplant or after transplant. We always tell the patients, you will see better with a contact lens, no matter what age you are. Patients who are unsuitable for cross-linking for some reason and don't want to transplant this, definitely go into the contact lens clinic. Of course, the disease must be stable. If it's progressing, we really want to go ahead and do cross-linking. Corneal thickness has to be close to 400 microns. That's what the machine has been approved for in the United States. Corneal transplant is reserved for advanced corneal ectasia and patients who are intolerant to contact lenses. A bit about contact lens fitting. It's an excellent non-surgical option suitable for patients on any spectrum of the disease. You know, if I can quote Davy Jacobs, there is no cone that cannot be fitted. You just haven't tried hard enough, you or the patient. It does not preclude any surgical intervention. Relatively low maintenance. Of course, the cost can be an issue. Fortunately, for most medically necessary contact lenses, we are able to get approval from the insurances here. Disadvantages, of course, you need a proper person, a proper team who can do medically necessary contact lenses. And as I mentioned, they can be slightly expensive. As I said, there is no cone that can probably not be fitted. We rely a lot on large lenses that sit on the sclera. You have many versions of these lenses. If the patient is intolerant, you can use piggyback lenses as well. So overall, you know, these patients are very happy. There's some excellent work published from South America that has shown that the need for corneal transplant in these patients with ectasia has really gone down. This is a patient who had a corneal transplant for post-LASIK ectasia done many years ago. Fortunately, the patient did not progress further. There was no further ectasia after this transplant, and the patient did well with contact lenses. Collagen cross-linking, really the savior these days. You know, we don't need to go into the details of the procedure. We still do epithelium off cross-linking again, because that is what has been approved by the FDA up to now. Everybody on this call, I'm sure, knows how cross-linking really, there's a frame shift from a level of lower biomechanics to higher biomechanics. That's how cross-linking works and stops the progression of disease in these patients. Various types, conventional cross-linking is what we do here. Lengthy procedure, takes time. Some of us on this call will have access to epi-on cross-linking. I used to do that when I was working in another country. We used to do hyposmolar riboflavin in thin corneas, which can be important in post-LASIK ectasia. You can do high fluence if you have access to that machine. We have shown in the past that high fluence really works as well as the conventional cross-linking. And I'll just briefly mention about combined procedures in these cases. So this is an example of a 52-year-old patient, LASIK done in 2003. You can see they're all like more than 15, 20 years ago, when patients really don't remember who did their initial surgery. Approximate pre-op myopia was about minus 10 diopters. Visual acuity was 20/70 in the right eye and 20/30 in the left eye. This is the right eye, astigmatism of 1.6. You can see inferior steepening. The central cornea is about 409 microns or so. Cross-linking done. These are the three things that I definitely pay attention to. You cannot not avoid thinking about the flap, especially the hinge. So you really don't want to lift the flap up. Well, you know, you said there are some publications, mainly from China, where they have actually lifted the flap up and then did the cross-linking, but we keep the flap on, we remove the epithelium. I use alcohol delamination, especially in these patients, because I don't want to press too much on the eye, on the epithelium, just because of that flap. Although most of these patients, the flaps are old and they are sort of strong, and do expect diffuse lamellar keratitis or DLK in some of these patients. So I don't use much steroids after my routine cross-linkings for primary ectasias. But this is a scenario where I make exception, and I saw these patients usually on fluoromethalon. They do really well, and sometimes they need steroids for a month or so. So really, these three exceptions there. Same patient had cross-linking done, and you can see like 3 months down the line, you can already see some flattening here in the follow-up visit after cross-linking, even in a 52-year-old patient. So that's the same patient, 6 weeks 20/60, 6 months 20/50, and you can see at end of 6 months, astigmatism of 0.5 and myopia of 2.5 diopters, and patient could see 20/20 even with glasses. Corneal transplantation, needless to say, these patients, they have ectasia that really extends to the peripheral cornea. you might need a large graft if you're planning to do a penetrating keratoplasty. Even a lamellar transplant, you really need a large graft because you want to encompass that area into your graft, and you really want to do tight suturing. It can be really challenging because the corneas are thin. So if you have access to femtosecond laser, that might be a useful tool, especially if you are performing a large lamellar transplant. And this is something that I did as a fellow with Dr. Tityal and Dr. Namsa. They're on this call. We basically removed the flap and tucked in a graft, a lamellar graft in these patients. This was published way back, but it still works very well in selective cases. A tuck-in lamellar keratoplasty. This is a technique that was described, of course, at RP Center in Delhi by one of my other mentors, Professor Vajpayee, for extreme corneal ectasia and for post-LASIK ectasia that involve the periphery of the cornea and especially have a decentered cone. A diagrammatic representation of such a patient, where you basically create a pocket in the periphery. You can really do with femtosecond nowadays, but this was 2008. When we did not have access to femtosecond, and you basically could tuck in those edges right until the periphery of the cornea. So this potentiates the thickness of the cornea, especially in the periphery. And these patients, the surgery takes about 2.5 hours. I still do this once or twice a year for some patients here, and expect to put in about 24 stitches. So very good case for your fellows if they want to learn suturing. This is an example from a published paper of ours where we did a tuck-in lamellar keratoplasty. As you can see, large graft, but still lamellar, no chances of rejection, endothelial graft rejection. Works really well, definitely needs a contact lens for better vision after surgery. Not a big fan of doing cross-linking with other things, because especially in post-LASIK ectasia, but there have been a few publications where people would do PRK and cross-linking for patients who have ectasia. In my opinion, we do not have definitive evidence that this really works in the long term. So to conclude, post-refractive ectasia is fortunately a rare complication. Corneal tomography is still the best modality for early diagnosis. Management really depends on the severity of ectasia and if the patient, the ectasia is progressing or not. Contact lens fitting, really, if you are in a big practice, you need to have access to a person who can do really good medically necessary contact lenses. That really changes everything for these patients, especially if they do not need a graft and you can get away by doing cross-linking and they do not need a transplantation. And if you do, you really have to resort to certain special techniques of corneal transplantation. Thank you very much for your attention.
Thank you very much. Professor Sharma?
Yeah. So I think much has already been talked about keratoplasty, post-keratoplasty astigmatism, and so it may be a little repeat, but I would be talking to you about pearls in keratoplasty astigmatism. There are no financial or proprietary interests, and 15 to 30% cases of keratoplasty may have astigmatism more than 5 diopters, which is often irregular and is associated with higher order abrasions. And the early post-op may be there because of sutures in situ, and the late post-op may be there without the sutures, and this is governed by different factors. So the early post-op, which is because of the sutures in the situ, is because of symmetry of suture positions, depth of the suture track in the graft and the recipient, homogeneity of the suture tension, and the late post-op is related to the quality of the cut, the wound configuration, symmetry of graft placement, as well as wound healing. Recipient pathology does play an important role in post-PK astigmatism. For instance, it will be more for keratoconus than in Fuchs. Also in cases like with peripheral thinning or ectasia or focal edema or focal scar, or if there's vascularization or if there's a preceding keratoplasty or an eccentric graft, more so in aphakia, and also the topography of the recipient, possibly, especially if it is not normal in the periphery, may play an important role. The preoperative donor factors may also have a role to play. Age of the donor, because the infants tend to have steep corneas. Topography of the donors, although it's not a routine that is done in eye banks, And so you actually do not know the topography of the eye bank corneas which we are transplanting. Now, fixation rings, such as asymmetrically placed fixation rings, when we are doing the surgery, can induce astigmatism, and so can the lid specula if it is having it is putting a pressure which is not symmetrical. And the ring ideally should be, if you're putting a Flerenga ring, should be ideally equal distance from the limbus. 4 to 6 interrupted sutures should be put at regular intervals, and equal suture tension should be there to prevent undue astigmatism. Then as far as the trephination is concerned, endothelial side, you can have a round hole, but epithelial side, you can have a oval opening. And if the opening is not absolutely round, then again, this can lead to post-op astigmatism. The trephine types also play an important role. You can have handheld trephines or the suction trephine, and the Hesburgh-Barron trephine, where the recipient trephine has crosshairs for centration. And the donor trephine may get tilted, so that has to be avoided by 4 metal rods that are there corresponding to the peripheral holes for suction. Now, this is just to show how the centration of the center of the cornea is marked, and trephination of the host cornea is done using the marks which are there, so that you have a absolutely central and a circular trephination that is done, which is round and which is not oval. And if you are a novice surgeon, then it always helps to make those radial marks to help you to suture the graft. Then eccentric trephination can lead to irregular astigmatism, and the flat axis of the astigmatism is towards the direction of the decentration. Now, this is just to show a case of eccentric trephination with high irregular astigmatism of 13 diopters because of an eccentric graft. Of course, femtosecond laser keratoplasty trephination can also be done, and we can do it on the donor cornea also. The endothelial cell loss when you use femtosecond laser is 20%. Astigmatism is less than 3 diopters, and the patients do have early visual rehabilitation. And we did have a wonderful talk by Dr. Aldawe on this. So this is just to show that when you cut the, when you excise the cornea, your blades have to be absolutely perpendicular or vertical, and try and leave no ledge. And in case the ledge is there, which is left, then that ledge should be removed, especially the posterior part. And this is just to show the trephination which is done of the donor cornea, and the donor cornea is then placed onto the recipient bed. And of course, the first 4 suture placement first placement of the first 4 sutures is very important. All of these should be equidistant from each other, and you should have the classical quadrangle that has been described for this. And the sutures are then given on the previously placed marks. This would help, especially the surgeons who are learning to do keratoplasty. Intraoperative keratoscopy has a role to play, and some of the operating microscopes do have this reflex which can be seen while suturing, and so your sutures can be adjusted accordingly. Now, sometimes just by suture removal, one can help to decrease the astigmatism. And in this, the symmetrical sutures were there in DALC for keratoconus, and this astigmatism is about 2 diopters. And this is a combined and interrupted running suture which has 2 diopters of astigmatism, but notice that there is some amount of ectasia also which is present in the periphery. Way back, we published a paper where we compared TOC versus anti-TOC versus no TOC suturing techniques, and we did not find any difference between these 3 types of suturing techniques. Then selective suture removal can be done like this, especially for astigmatism more than 4 diopters. And topo-guided selective suture removal starts at 2 months, and after the initial suture removal, the non-adjacent sutures can be removed at an interval of 4 to 6 weeks. Now, this is just to show how 5 diopters of astigmatism before suture removal has decreased to 1 diopter after doing the appropriate suture removal in the steeper direction. If you have a continuous suture which is causing astigmatism, then again, suture tying forceps can be used, and the whole tension can be redistributed from the area which is steeper to the area which is flatter, and this can correct about 2 to 5 diopters of astigmatism. And this is to show the pre-suture adjustment and the post-suture adjustment. The post-suture adjustment, the astigmatism is only 0.96 diopters. Of course, incisional keratotomy can be done, but this is done at 90% corneal depth, anterior to the graft whose junction in the donor cornea, and can be done manually or by the femtosecond laser. It does have low predictability and high incidence of recurrence, but it can correct in some cases up to 6 diopters. Compression sutures again have been described, but I think they are not again very predictable, although in high degrees of astigmatism, these can be used. Excimer laser surgery can be done after keratoplasty, so one can do a PRK if the cylinder is less, but one can also do LASIK, and these have been described as simultaneous procedure where with the help of the microkeratome or the femtosecond laser, a cut is made so as to release the tension, suture tension, which is there at the graft host junction, and sequentially in the sequential procedure in stage 1, the femtolaser cut is made or the microkeratome cut is made. And in stage 2, 4 to 6 weeks later, the relifting of the flap is done and the laser is done. And this was an article which we published in Survey of Ophthalmology on LASIK after penetrating keratoplasty to treat astigmatism. Now, this was a case where femtosecond laser is being used to actually create a flap. And although this flap was almost a little beyond the graft host junction, so the flap is elevated and is released back, is put back again. So the idea is that basically the tension forces which are present at the graft host junction are released. And 6 to 8 weeks down the line, one can again relift the flap and then treat the astigmatism. Now, this was a case where we were trying to do this in a case of DALC, and we did see that there's some amount of retraction which is there, the arrow in the black. You can see the flap where it is there, and this is the arrow in the yellow shows the graft host junction. So a little bit of retraction may be there in such cases. Of course, intrastromal corneal ring segments can be given for post-keratoplasty astigmatism as well. And this was a case where toric intraocular lens implantation was done because there was also presence of cataract in this case, which was done post-DALC again. And after marking the axis, the intraocular lens is placed, and this would take care of some amount of astigmatism, especially the one which is lenticular. Of course, there is a caution for cases like DSEC, because if the astigmatism is high, then you, rather than doing a repeat DSEC, you should do a penetrating keratoplasty, because even if you do a repeat DSEC for a failed DSEC with high astigmatism, the astigmatism is not going to get corrected. So to conclude, one has to have selection criteria which is stringent for donor corneas. Classically, this can be done historically from the attendance of any previous disorder such as corneal ectasia in any form. One has to take precautions intraoperatively in terms of centration, trephination, suturing, and keratoscopy, diagnose high astigmatism postoperatively, and take appropriate measures timely. Thank you very much for your kind attention.
Okay, wonderful. So I think that although we started off a little late, we are pretty much on time. I'm just going over the chat box here to see if there are any questions from our audience. I don't see anything here. Anything from our speakers?
I have a question about using toric lenses after penetrating keratoplasty. What criteria does everybody use to discuss that patient? Because obviously the graft may fail, they may need another graft, and how do you manage that situation in terms of patient expectations when you're doing toric lenses in patients who've previously had grafts, especially if these grafts are older, 20, 30 years or longer? So
I think these patients are also older, I hope, because they have cataract and they have post-PK astigmatism. But I think you do have to counsel them that they may need a change of intraocular lens if their graft fails. And of course, preoperatively, you have to ensure that there's not too much of irregular astigmatism, because then that is not going to get corrected by the toric intraocular lens. So I think this is something that the patients have to be prepared for, because their corneas might change, and then the lens which is there in situ may not hold good. Dr.
Yeah, I
Basak.
mean, sorry, go ahead. Go ahead, Dr. Basak.
Sir.
So I have a question. Like I recently have a patient, a failed PK, young lady, 15 years PK, and she is now around 43 with relatively posterior subcapsular cataract, and she is having 28 diopter of astigmatism. So how to proceed this case?
Was reasonable. Like, oh, sorry, go ahead.
Sorry, no, go ahead, Dr. Yuri, please.
Thank you. I mean, you definitely have more experience with these cases than me, but
just I saw it 2 weeks back. So I'm planning to how to, because power cannot be measured in this case, and K-max is around 78 or 80, something like that. So what I thought, that I counsel the patient like this, that I'll be doing regrafting and of course PK because of huge astigmatism, keratometric astigmatism, and I do ECC. I'll not go for IOL implantation now, and because it is posterior subcapsular cataract, so I can wait fairly well for a year or so. After all suture removal, I will then calculate the IOL power and put IOL. I have counseled like this. I do not know. I have never, this kind of astigmatism I have never faced. Like with clear cornea, clear lens is fine, but cataract is also a component of it.
Dr. Basak, do you know why does she have this much astigmatism? Like, is it ectasia somewhere? What is, or just trying to understand? 28 is quite a bit. Is it
quite a big?
So
yes.
Yeah.
It is.
So,
it is a kind of ectasia at the graft-host junction.
Okay. Okay. I mean, I would really.
No thinning is there, but it is ectasia and half of the area of.
And the graft is endothelial failure, or is it hazy graft?
It is a delayed graft failure. 16 years back that PK was done.
Yeah, I mean, I would agree. You can do a staged procedure, especially in a young patient who has only posterior subcapsular cataract. I would, if I'm doing a graft, if the endothelium is not preserved, of course, it's a failed graft. You will have to do a larger graft. The technique that I just showed to tuck in, that still works. I'm sure you're well versed in that technique. Once that is done, I have seen the astigmatism goes down drastically. It's not going to be from 28 to 2, but I've seen, so the maximum I've seen is, astigmatism going from like 17 to about, 6 diopters or so. The last patient I remember, who was quite happy. He unaided, even with the cataract. So my patient had a cataract, not too bad though. His unaided vision went from like counting fingers to like 20/100, which is what, like 624 or so, 636. And then, once you do the cataract surgery, that can be done. Depending on how the stroma is, I don't know if EK will be an option in future, but with 28 diopters, that would probably not be an option at all here. So that's my take. I think for post-graft ectasias, I have never seen a patient who does well with simple graft replacement. You will have to do one of those, like Dr. Soberman mentioned, plication sutures to reduce the astigmatism first. And I think Shiraz Daya and Massimo Busin, they take out a chunk of lamellar graft first, and then do the plication.
Wedge-shaped kind of keratoplasty.
Yeah, and I've seen Massimo doing. He actually opens the wound and resutures it. Shiraz does that as well. I've seen his presentations. So that's a challenging case. But I would do a stage procedure. I don't know what others think.
Stage test.
Yeah.
I would agree. I think the important thing also here is that the age of the patient, is if you don't do anything like a new graft here or a full thickness graft, is the cornea going to last another 40 years? So I think it makes sense if you're considering if the cornea is already edematous and ectatic to repeat a full thickness graft here and reset the cornea at least before doing cataract surgery.
Yeah.
Yes.
Shehzad, the case that you mentioned earlier, the scenario, I do the same thing. You got to tell the patients that the graft might fail. I try and get a specular done. That's one of the rare instances where I get a specular done and show the patient you already have 1,500 cells or less than that. But fortunately, and I'm sure you already know this, if the graft fails, it won't in your hands. But if it does, you can always do an EK under that failed graft if there is a need. But yes, I agree with you. You got to counsel the patient that the graft might fail, especially if it's more than 10 years old, a full thickness graft.
The other issue that at least I've run into is that if you don't fully correct their astigmatism, it's really hard to fit them with contact lenses. Now you have a graft with a toric lens where RGPs are never going to work, and even scleral lenses, your amazing contact lens fitters hate you then for sending those patients to them because it's really hard to make any of those patients happy then.
Yeah, I agree. And, it depends on the post-op astigmatism. Even if your graft stays clear after your toric lens, the residual astigmatism is always an issue. But again, Dr. Murata mentioned that you can do a surface ablation. I've seen, I've done PRKs on patients who have, to the tune of about -3, -4, astigmatism without much spherical error left after cataract surgery in a situation like this. Sorry, I missed that point if Dr. Namrata already presented that, but she did, and then Busen did earlier as well, just creating a flap with microkeratome, lifting and repositing the flap, that reduces the astigmatism by a diopter and a half. Am I right, Dr. Namrata? You published that as well.
Yeah, quite right.
I just wanted to make one small point that just remember that sometimes by doing just endothelial keratoplasty under these grafts, you take the edema. The edema does tend to flatten these grafts. Sometimes you see this after they clear up, there's all of a sudden more astigmatism. So just something to consider.
Yes.
Absolutely. Yeah. You try doing a graft with pre-op thickness of 750, and suddenly the patient's graft is going as clear, but you have astigmatism of like 4 diopters. I've been there. I'm sure everybody has been there. So
we all have.
Important point. Yeah. Thank you.
Okay. So question for you, Vishal, obviously about cross-linking. Do you get the notion that these post-LASIK ectasia patients do as well with cross-linking as keratoconus patients?
They do actually. I've been very pleased with what I've seen. We've collected oddly about 30 cases over the past 3-4 years, which is a big number, unfortunately. One thing that I was discussing offline with Shehzad is that I don't wait too long to document progression in these patients. As you've seen, even if your patient is like in 50s or 60s, they usually progress because otherwise they won't present to you.
Yeah.
Something is bothering them, and that's why. So I usually schedule them for a procedure, cross-linking 3 or 4 months later, and I repeat corneal tomography on the day of the surgery. And invariably there is some progression. So of course the pathophysiology is slightly different compared to primary ectasia, but they seem to do very well. I haven't had to repeat cross-linking in any of my patients of the past 5 years, but 5 years is not a long time in these patients.
Yeah, I agree. I just recently had a patient that I did cross-linking for post-LASIK ectasia and then did her cataract. aim for a little bit of myopia. She ended up being something like 20/30 uncorrected. He's super happy. So yeah, I think that the other eye will go just as well. I'm fearing those super demanding patients like Dr. Kuz.
You know, speaking of patients who are demanding, I think the one thing that a lot of clinicians tend to look over or don't think about much is quote unquote newfound keratoconus in patients who present in their 60s or 70s. A lot of, many clinicians would counsel a patient, oh, you're in your 60s, it's not going to progress, just go ahead with the cataract surgery. The one thing to remember is pellucid marginal does sort of present later in life like that, and it can be progressive. So I think the having not just topography but tomography for some of these patients who have both cataracts and sort of funny looking corneas are super helpful.
So we'll move on to the next topic, which is
Dr. Basak, you should send everybody an email after you're done with your 28 diopters case.
Yeah. What did you do?
Okay, I'll say I'll share that.
We'll get hold of you in AAO, but that's far away. So let us know what happened.
Yes.
We'll get you in Kochi before that, Vishal.
Oh yeah, I'll see you guys, of course.
Yes.
Yeah.
Everybody is invited. Your trip is due, Shehzad, for quite some time now.
I know.
We keep talking about it, but it has not happened. So
I
anybody,
need to come on the same plane with Vishal.
I know. I was actually convincing Shehzad last time we were in this meeting together that we should do it this time. We should go.
Thank you. You are also invited, Yuri and Ellen. Most welcome to join in our All India Ophthalmological Society meeting, which is going to be from May 11th to May 14th in Kochi. Kochi is a beautiful place with backwaters and very, very scenic in South India.
God's own country.
God's own country.
Wonderful. Thank you kindly. And thank you so much for having us today.
Thank you so much.
What a
We
terrific
have to
meeting.
thank Cornea Society for collaborating with All India Ophthalmological Society. And I think this is the third time and for us when we are doing the International Ophthalmic Conclave. And I'm so happy that every time we have Cornea Society. So thank you so much for being with us. Thank you.
Thank you.
Thanks so much.
Bye-bye.
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 Thank you.